So thank you for joining us. We're going to start with the
He shot it turning now.
We have 4 projects that we will be presenting. The first one is from Rising Child Center, Inc. They are going to establish a new program, MHC 2913, and Tiffany Mott will be
And then the Young Spirit projects, I believe.
taken away.
In New York City, so I think we can do those. Okay.
Maybe it's just.
Would you like to join me at the table? Oh, okay. Thank you, Mr. Frank.
Apologies, because I have to go back. We will start with the voices.
Oh, here it is.
Added, so probably one will not be as ready. But.
Okay.
Want to take it out?
Yes.
Oh, I'm sorry. I missed the introduction. I apologize. I just wanted to mention that on the agenda, it did say that this was to establish a motors program, but I will share that that was actually incorrect and what it actually is, what the agency is proposing. Rising Child Center, a newly organized non-for-profit organization, is seeking to establish a CFTSS CMHRS program to provide other licensed practitioner, community psychiatric supports and treatment, psychosocial rehabilitation, youth peer support, and family peer support services in Rockland County. The application was originally submitted under Legadel, an entity licensed under a religious corporation law, which was determined to be a type of organization that is ineligible for OMH licensure during the review process. Located in Spring Valley, Legadel has been providing mental health services under the New York State Education Department waiver to youth and their family members facing emotional, behavioral, and psychological challenges in Rockland County since 2021. Access to mental health providers has been identified as one of the top 3 concerns reported by survey participants according to the 2022-2024 Mid-Hudson Community Health Plan. This is one of the main reasons Rising Child Center is now looking to integrate additional mental health services with developmental and educational support to a proposed capacity of 200 children, adolescents, and young adults ages birth to 21. Their mission will be to implement preventative measures and enhance public awareness of behavioral health needs and community-wide resources. The county and OMH have supported this application with minor conditions which are outlined in the summary. And representatives from Rising Child Center are present today in Albany to address any questions.
Is there any questions or comments for the members of the group?
Sure, if I can, if you don't talk about sort of your philosophy of treatment. I mean, it's one thing to talk about community education, all those sorts of things, but there are also kids and their families that need taken care of. So talk a little bit, if you don't mind, in training to support those.
Sure. So firstly, to Bernack, I'm founder and president of Legadel and Rising Child Center, and I want to thank the whole team of the OMH of working together on this project. So I think the question is a very important question because it's not only when it comes to mental health, it's just not working with an individual. It's a family dynamic, it's a community dynamic, and I would say that one of our most important reasoning when it comes to mental health and the training we got and the experience we have is to work on a family-based treatment plans, which is crucial, and that makes a huge difference when we have the community supporting the individual versus not. So I appreciate that.
Thank you.
Any other questions?
I have a question here in New York. This is Debbie Ann. If we could take a look at the budget, please. I'm looking at your fringe benefits and I'm seeing a 10% compared to an admin cost of 18%. And I'm wondering how you're able to work within a fringe budget of 10%.
So when we put together the budget and we put together the fringe rate, it was based on past experiences because we have other projects that we do. We just the way we want to do it. We want to try to give as much as possible for the services needed. It did come out that because we might be able to share some administration staff, I don't think it's going to cost us that much. But we still do have some room to adjust if needed. But it's definitely something that we looked into.
So I understand the adjustment of the administrative cost. The fringe is the benefits to the employees. And so I'm wondering how you're going to fit them into that 10%, or if this is something you'll relook at, because 10% seems very low for fringe costs.
I appreciate that. We will definitely look into that to see if there's any adjustment needs to be made there.
Thank you. Is there any other questions or comments?
Yes.
Yes. So, kind of related.
Oh, we can't hear.
Any questions or comments?
Yes, there's a question here in New York.
Okay, well, go ahead.
Can you hear me? Just related to the earlier question, we talk about the number of FTEs for your clinical positions. Can you talk a little bit about what you're looking at in terms of the peer support roles? And will those
Oops,
will those individuals?
just lost the connection there, you guys.
Oh, wow. It's on now, it's on now.
The question relates to your peer workers. Can you describe the functions of peer workers in your program?
Yeah, sure. So we did start I know we started on a very low, FTEs when it comes to peer support, UPST and family peer support, because that's something that's new. We didn't do it in the past. We wanted to start slowly with that. But once that picks up and we see that there's a need over there, we'll definitely be willing and ready to expand on that.
And what do you see as the function of that role? And are they considered per diem workers? Is that why they will not be considered as needing fringe benefits?
Again, what was the question?
What is the role of the peer advocate? Is it going to be a peer per diem, or is it going to be full-time?
So I think we have put it in. I think there was more part-time, because usually the way the peer support will work, it's going to be most probably after hours, going down to the. So I don't think they'll have full-time peer support. That's what I think in the budget that we put together, if I remember.
Any other questions? Comments? If not, I will make a motion to recommend approval of this project. Can I have a second?
Second.
All in favor, say so by saying aye.
Aye.
Opposed? Abstaining? Motion carries. Thank you very much. We'll move to the second project, which is Mount Roosevelt Mornings. It's a capital project, increase. And the time is it will be presented by us.
Thank you.
You can take it away, and Sarina will be recusing from this project.
Sorry, who is being recused? Who is recusing themselves?
Will be recusing.
Dr. Lim,
Thank you. Oh, okay. Okay.
who works for Mount Sinai.
CPAR 184, St. Luke's Roosevelt Hospital Center, Mount Sinai West. Mount Sinai West seeks approval to expand the space of their existing Comprehensive Psychiatric Emergency Program, or CPEP, satellite, located on the ground floor of the West Building. The main CPEP location is located at Mount Sinai Morningside, and with the satellite located at Mount Sinai West Hospital on 59th Street between 9th and 10th Avenues. Their plan is to increase the square footage from 970 square feet to over 3,600 square feet. This expansion will allow for the addition of clinical spaces and 4 additional extended observation beds, which would result in a total of 5 extended observation beds to serve the adult population. The renovation project will be completed in 2 phases so that the CPEP can remain open and operational. The construction work will be separated from other existing areas of the hospital through use of temporary doors and partitions without compromising life safety, thereby limiting any disruption to the ongoing operations of the adjacent clinical areas. The anticipated start date of the Phase 1 renovation is January 2nd, 2026, with an anticipated completion and fully operational target date of April 30th, 2027, following both phases of the renovation. The county and OMH have supported this application with conditions which are outlined in the summary, and representatives from Mount Sinai West are in the New York City location to address any questions.
Any questions or comments about this project?
If I may, just what's been the historical utilization of the CPAP that would argue for expansion?
Yeah, sure. Sorry, the question was, what's the reason for the expansion?
Historical utilization that would argue for the expansion.
Why do we need more beds? Oh, yeah, sorry, it's just that we are frequently on diversion because our CPAP right now only has, I think, 3 or 4 rooms. So we need to create more space in our CPAP to prevent us from going on diversion and having to board patients in the medical ED.
Great, thank you.
Any other questions, comments? If not, I will make a motion to recommend approval of this project. Can I have a second?
I'll second.
All in favor, stay so by saying aye.
Aye.
Opposed, abstaining, motion carries. We'll move to the next project. The applicant is Columbia Memorial Hospital. CPAR 197 is a capital project and capacity increase. And it's an type is inpatient. And Alex Posey working for Alex.
One moment, we're just getting settled here. Okay. CPAR 197, Columbia Memorial Hospital. Columbia Memorial Hospital is proposing to expand their inpatient psychiatric program by 20 adult beds across 2 floors of the existing hospital. They intend to perform a renovation of over 4,400 square feet on the 5th floor to accommodate the addition of 6 single occupancy rooms and 1 double occupancy room for a total of 8 adult beds to their existing unit. The existing unit's social and dining area will be expanded to accommodate the increased number of patients, and additional consult rooms will be added. The existing nurses' station will be expanded to allow direct staff visibility to the new expansion, patient bedroom corridor, and social areas, while maintaining a central staff core area with access to the existing medication room, staff lounge, staff bathrooms, and emergency equipment storage. Staff offices and conference rooms supporting the unit will be relocated within the space to accommodate layout. Additionally, over 8,000 square feet of a currently unused space on the 2nd floor will also undergo renovations to allow for the addition of 6 single occupancy and 3 double occupancy rooms for a total of 12 beds, dedicated to serve the geriatric population. All construction is planned to occur simultaneously and is estimated to be completed in 6 months' time. There is no anticipated impact on the current inpatient bed capacity during the renovations. Columbia Memorial Hospital received a $5 million grant from the Office of Mental Health to expand their inpatient program. They demonstrated that there is a growing demand for these inpatient services for adults and also for the aging population. The county and OMH have supported this application with conditions which are outlined in the summary, and representatives from Columbia Memorial Hospital are here in Albany to address any questions.
Any questions, comments?
I guess I'm curious if I may, just the data that's in here about, which is unnerving about how many people had to wait in the ER, by the way. But is that residents from the closer geography to Columbia Memorial, or is that Albany County?
Yes, so that's mainly Ulster County, Columbia, and Greene counties.
Gotcha.
Any other questions? If not, I will make a motion to recommend approval of this project. Can I have a second?
Second.
All in favor, say so by saying aye.
Aye.
Opposed? Abstaining? Motion carries. Move to the last
That was easy. I hope so, yeah.
applicant is St. Barnabas Hospital, CPAR 213. The project is capital project and capacity increase. The program type is inpatient, and Rudy areas will be presenting. Rudy, if you can take it away.
Rudy's actually not here today, so I'll be presenting St. Barnabas as well.
Okay.
St. Barnabas Hospital is seeking approval to increase their inpatient psychiatric capacity from 49 to 72. This increase of 23 beds will be achieved through the gut renovation of space on the 4th floor, which will be renovated to establish a new 24-bed adult inpatient psychiatric unit. The space currently houses a 24-bed substance use disorder withdrawal and stabilization services unit, which will be relocated to the 6th floor. 2 existing inpatient psychiatry units located on the 2nd and 3rd floors, currently with a 24-bed and 25-bed capacity respectively, will also undergo gut renovations. Upon project completion, St. Barnabas Hospital will end with 3 24-bed adult inpatient psychiatric units and a total capacity of 72 beds. The renovations will be completed in 3 phases to prevent any disruption in the provision of inpatient psychiatric care. The updated inpatient program will have modernized environments, will be compliant with all codes and standards, will have added features such as de-escalation rooms and common areas, improved patient and staff safety and comfort, and an improved nursing station to facilitate direct patient observation during care. Construction is projected to begin in May of 2026, and each phase is anticipated to take approximately 8 to 9 months to complete. The anticipated construction completion date for the project in its entirety is in mid-September of 2028, with all 72 beds projected to be fully operational in late October 2028. The county and the Office of Mental Health have supported this application with minor conditions which are outlined in the summary. And representatives from St. Barnabas Hospital are present today in New York City location to address any questions.
Is there any questions?
Yes. Yeah, one question I have. Overall, I just want to make a comment, probably more to the state, but it's really good to see after about 3 or 4 years that we're seeing an increase of psychiatric beds back into the system after COVID. And this was something we raised right after COVID, the concern of the loss of these beds. So kudos to OMH and the state, and particularly the hospital settings, for looking at this closely and making this readjustment back readjusting. The question I have is a minor one. It's just if you could tell us how the relocation of the stabilization beds, how will that affect or not patient care, how it will be adjusted? Because it's too fragmented. Go ahead.
I'm Frank Cicero, representing the hospital. We have representatives from the hospital. You're speaking about the Oasis beds?
Yes.
Yes, so they will be relocated to a new unit, reconstructed. There will be a slight decrease in capacity, but the decrease in capacity is above, the end number is above what the average utilization has been for several years. And that's also going to become part of the statewide grants as well that they received from the health department, and we have an application in front of Oasis on that as well. It doesn't come to this council.
Okay. And that would be adult beds or both?
Adult bed, yes.
Adult, okay.
I have a follow-up question to that, Frank. Hi, how are you? The question is, what's currently on the 6th floor where the beds are going to be
Currently on the
relocated?
6th floor, there's a sleep lab, which is also going to be either moved to a unit in the hospital, or we're going to do sleep at home. Also on that unit is physical therapy, inpatient physical therapy, which is also going to be located in a different hospital.
Okay, thank you.
Any other questions?
Yeah, one other question, if I may. We hear a lot about the workforce challenges across the system, and the project calls for almost 48 additional staff. I'm curious about how you're thinking about finding those people.
Yes, hello, Mark Edwards. So we definitely have a number of temp recruitment agencies, such as locums, that we have on standby should we do come across any recruitment issues. However, in light of us doing it in phases, we're actually going to start recruitment earlier than later to ensure that we fill the FTEs in advance of course, becoming operational. However, that is our mitigation and contingency plan should we need to, again, start operations prior to hiring fully or full-time employees for the services.
Thank you.
You're welcome.
Other questions, comments? If
Just a
not,
comment, just applauding St. Barnabas because I know what the needs are in that area, so applauding you for that work.
Tiro with that. We need increasing beds. I make a motion to recommend approval of this project. Can I have a second?
Second.
All in favor, stay so by saying aye.
Aye.
Opposed? Abstaining? Motion carries. We are moving along with Oasis projects. And with the Oasis project, we have 6 projects to present. The first one, the agency, is Simple Wellness. And it's CA number 2025067. And it will be presented by this is a new Oasis provider. Brian?
Hello.
Hi. Are you guys okay then with just grabbing other folks? Dina, are you guys okay then with grabbing other folks when you need them, or do you want us to stay behind?
Can you just sit in the back? No, it's okay.
Brian?
Your staff to come in? They're gonna come in with the project.
Present this project.
Go ahead.
Yep.
Yes, good morning and thank you. I'll be presenting Certificate of Need 254067, which is AMMGW Incorporated, doing business as Full Circle Wellness. They submitted a certification application requesting the New York State Office of Addiction Services and Supports approval to become a new OASIS provider. Full Circle Wellness proposing offering Part 822 outpatient services at 191 Olympia Boulevard in Staten Island. Services will include person-centered, trauma-informed, and a recovery-oriented philosophy. Proposed services include comprehensive assessments, client-centered treatment planning, and care coordination services. Their services will also include individual and group counseling based upon evidence-based practices. They will also include psychiatric evaluation and medication management. Medication-assisted treatment will also be available for the clients they serve, including ancillary withdrawal services. Their proposed services will address social determinants of health to include connections to housing, legal, education, and employment resources. Full Circle Wellness will also offer linkages in the community for the clients they serve, including medical care, family-focused interventions, and reentry support. Clients who complete their treatment service are offered continuing care to assist in monitoring their recovery. The proposed hours of this program are Monday through Thursday, 9 a.m. to 8 p.m., and Fridays through Sundays, 9 a.m. to 5 p.m. Need for services is supported by the Staten Island Community Board 1, New York State Office of Addiction Services and Supports, New York City Regional Office, and the New York City Department of Health and Mental Hygiene. Full Circle Wellness was formed as a domestic business corporation in January 2025. The entity has one owner, Anna Mendez. Anna is an advanced BHSAC and has more than 2 decades worth of experience in substance use disorder treatment, playing major roles in executive, clinical, and educational roles. Through her years of experience, Anna Mendez meets the criteria for an owner with substance use disorder experience. The applicant submitted financial documentation demonstrating available sufficient funding to support the initial 6 months of operations. Full Circle Wellness submitted a staffing plan for the proposed location that meets regulatory requirements and includes 1 full-time director of services, 1 half-time medical director, 1 half-time nurse practitioner, 1 half-time registered nurse, 1 full-time licensed qualified healthcare professional, 1 full-time credentialed alcoholism and substance abuse counselor, a health coordinator, 1.5 full-time certified peer recovery advocates. Full Circle Wellness reports that their proposed services will also include case management and care coordination. Their policies and procedures have been reviewed and do comply with regulatory requirements. OASIS's recommendation is to approve the request from AMMGW Incorporated, doing business as Full Circle Wellness, to become a new OASIS provider, Part 822 outpatient services, with the following contingencies: verification of the hiring of sufficient staff to meet regulatory requirements, copy of the filing receipt from the New York State Department of State indicating that the amended certification of incorporation, including the OASIS required language, has been filed, and OASIS inspection and approval of the facility. Anna Mendez is present in the New York City location if the committee has any questions regarding this application. Thank you.
Any questions or comments?
Just in New York City, it doesn't say whether it's serving adolescents and adults, and also total number of folks expected to serve. What's their capacity? And the final question, I know it's been an issue before, we don't really see the full budget. It's just the amount on page where there's a breakdown, so it's hard to really kind of get a sense of the budget. But the main questions are, who are they serving and how many people?
I'm right here. We're going to be, I answered the question.
Yeah.
We're going to be serving young adults 16 and older.
16.
The transitional age youth population.
Nice.
And what was your second question?
Just
budget.
About average of 80 on our census.
80 on the census.
Yes.
And then groups
And groups, individuals, psychiatric evaluations, medication-assisted therapies. We have peer support. Telehealth, we're going to be doing on-site and virtual to make it easier.
Thank you.
Just a comment, if I may. Congratulations. I think that's great. The first that I think we've heard of agencies trying to connect to the social care networks and the like. So I think that's great. Good for you.
Thank you.
Yeah. Thank you.
Any other questions?
One question.
Yes.
We've been requesting full budgets for a while, haven't we?
Yeah,
Who do we direct that to? The Oasis licensing infrastructure?
Yeah, I
Okay.
think we were getting it for a while,
Yeah.
and it seemed like all of the ones we got now, it just is gone, and it has no budget information other than the summary numbers, the total numbers.
I can speak to that. Hi, everyone. It's Dina Holmes, the Director of Certification at Oasis. Yes, we have shared the concern and the request from the council with our Oasis Council, and we've been issued approval to be able to start doing that. So we are amending our template so that it looks exactly like the one that you've been seeing from OMH, and we'll have the grid with the budget moving forward starting at the next council meeting. Sorry for the delay. I did hear your concerns I think you've raised it a couple times. I did bring it forward, and we reviewed it internally, and we're prepared to start sharing that information going forward.
Thank you.
Thank you. Thank you.
So before we vote then, if I can, so do we have a sense of what this budget looks like? Do you all have a sense of what this budget looks like?
Yes, we request copies of the entire budget, pre-operational and post-operational, and we look at it to ensure, A, that it's balanced. We look at it to determine the initial 6 months required startup. We also have our regional office review it if there's any concerns, if anything seems out of characteristic with rate codes, with the going rates for salaries and things like that. So we absolutely look at it. A lot of times we go back and forth with the provider when we have questions, but to date, we've not been sharing that as public information as in a level of detail that you have requested of us. So like I said, going forward, we will be including that information on a more detailed basis for you all.
So there's no concerns around the budget for this project?
Correct. Correct.
Okay.
Yes.
Is there any other questions or comments? If not, I will make a motion to recommend approval of this project. Can I have a second?
Second?
All in favor, stay so by saying aye.
Aye.
Opposed, abstaining, motion carries. Thank you. We're moving to the second project, and this is from Professional Counseling Services, Inc., that's the agency. They are requesting a change in ownership, and this is CA 2025-064. So, and it will be presented by Philip, please.
He's on his way in.
In a way.
He'll be here in 1 second.
Yeah, 1 sec.
Oh, absolutely. We have all kinds of time.
Says who?
Philip, join in on
Hi, I'm Phil Plessis, Bureau of Certification.
Thank you.
The case I'm reviewing is Professional Counseling Incorporated, number 254064. The owners are requesting Oasis approval for a change of ownership They are a certified existing Oasis Part 822 outpatient service. Kristen Botwinick, Carolyn Morgan, and Jeffrey Mahar have proposed selling the establishment in its entirety. Upon approval for a change of ownership, the structure will be one sole proprietor, Augustine Krakow, holding 100% of the company's stock. Mr. Krakow does meet the requirements for experience in managing substance abuse disorder services. The program will continue to occupy the property at Medical Center West, Suite 118, Floor 1, 5700 West Genesee Street, Camillus, New York. PCI is an established service in good standing. The new owner plans to continue services without interruption or changes to the existing practice. Continuing care with existing referral agreements. There are no planned changes to services, staffing, or policies and procedures as a result of this action. Onondaga County Local Government Unit and the Central Regional Office recommended approval. And Oasis Bureau of Certification recommends approval with the following contingency. A copy of the fully executed sales document for professional counseling services demonstrating that Augustine Krakow is the sole owner.
Are there any questions about this project? We have two people from Professional Counseling Services here in Rochester to answer questions. Are there questions or comments?
Yeah, if I may, I just have two questions. One, the recommendation is that a copy of the fully executed sales document has to be provided to Oasis. So has the sale been executed or not?
So we do have a contract signed, but obviously it's pending approval. So I do have access. I can get you guys that document that we have.
Okay. And the second question is the sale by stocks, exchange of stocks, or is it by other means? It wasn't clear to me.
An exchange of stocks.
It's a stock purchase agreement.
It's a stock. Okay.
Any other questions? Comments? If not, I will make a motion to recommend approval of this project.
I'm sorry, I had one quick question.
Okay, go ahead.
And, you read these things and you forget until you slide down. So, could you tell us if there will be any connection and what it might look like between the New York program, Professional Counseling Services, and the location that's in South Florida?
No, I mean, besides Gus's ownership, there will not be a connection between those two. Some of us,
Referral of clients, that includes referral of clients?
no different than, we've worked with Professional Counseling Service previously years ago, but other than that, no.
Okay.
Any other questions or comments?
Thank you.
If not, once again, I'll make a motion to recommend approval of this project. And can I have a second? Can I have a second, please?
Second.
All in favor, say so by saying aye.
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 Opposed? Abstaining? Motion carries. Thank you very much. Thank you. Yeah.
Thank you.
Thank you.
The next project provider is the New York State Psychiatric Institute. They are a new Oasis provider. The CA 2025-003. And Jennifer will be presented. Jennifer, you take it away. Is Jennifer?
She is on her way in.
Okay.
Down the road.
So there's not a lag. Yeah.
This is so interesting.
Okay, Jennifer's here. We're ready to begin.
Okay, Jennifer, go ahead.
All right, this is New York State Psychiatric Institute. They're requesting OASIS approval to become a new OASIS provider of Part 824 Specialized Services for problem gambling outpatient treatment located at 1051 Riverside Drive in New York. The action is based on changes which were made to Part 857 Problem Gambling Treatment and Recovery Service Regulations, which require all OASIS funded and approved problem gambling treatment providers to become certified or designated by OASIS. NYSPI has been providing problem gambling disordered services under the OASIS auspice since 2005, when statute of authority was transferred to OASIS by Office of Mental Health. The New York Psychiatric Institute is a long-established entity, one of the first institutions in the United States to integrate teaching, research, and therapeutic approaches to the care of patients with mental illnesses. It has affiliations with entities such as New York Presbyterian Hospital and Columbia University Department of Psychiatry. NYSPI has been providing services to a significant portion of the persons presenting with issues for problem gambling in the New York City area. Their program only treats patients with a primary diagnosis of problem gambling disorder or those with problem gambling. Or diagnosis of gambling disorder, or those with problem gambling. Treatments are based on both CRAFT and CBT therapy. Services provided include both individual counseling and group therapy. The clinic also provides screening and assessment services, and all services are provided to both the problem gambling patient and the concerned significant other patient. Clinic hours are regularly Monday through Friday, 9 a.m. to 5 p.m., but they have the flexibility to accommodate patients who may present with the need to schedule appointments outside of this general schedule. NYSPI receives $84,621 in funding from local government aid and $405,585 in net deficit funding from OASIS through the Research Foundation of Mental Hygiene, who acts as their fiscal intermediary. This funding supports the day-to-day operations of the program and access to services for patients regardless of their ability to pay. Their budget identifies net operating costs of $490,226, resulting in a balanced budget. The provider does not have the ability to submit for reimbursement for services through New York State Commercial, Medicaid, or Medicare due to being a research institute. Staffing meets minimal staffing requirements, includes a PhD clinical director and an LCSW assistant director who meet the OASIS qualifications as qualified problem gambling professionals. OASIS recommendation is to approve the request from New York State Psychiatric Institute to become a new OASIS provider of Part 824 Specialized Services for Problem Gambling Outpatient Treatment with no contingencies, as the policies and procedures have been reviewed and accepted.
Any questions?
Yeah, I do, yeah. A couple, if I may. One, will there also be research going on with regard to the patients receiving care in the clinic? So that's one question. And two, in the application, there's a reference to people with coexisting substance use and mental health conditions being referred out. This is, I know I'm probably going to ask a question that's beyond my pay grade, but a lot of people with gambling problems also have other challenges in their lives. So could we talk a little bit about where those boundaries might be? Who's going to get care in this clinic and who might be referred out and where?
So we have 3 representatives in New York City, and we have OASS Director of Problem Gambling Services here in Albany with us.
Okay, yes, hello. First of all, thank you all for inviting us here, and it's a pleasure to present our program here. So, yeah, those are very good questions. So the first question relating to research, though we are a research institute at New York State Psychiatric Institute, the clinic itself does not involve any of its patients in research. The only kind of connection that is conceivable is that patients who end up on our waiting list, which is an extensive waiting list, they could be referred to research studies in the building that are separate from the operation of the clinic. So they, that would be an option that they could be given actually as a, instead of waiting for 4 to 8 weeks, for example. But they don't do any. We don't actually do any research within the certified program. So that would be the answer to that first question. Regarding the second question, I think that's an excellent question. To a lot of patients who are coming in, first of all, we have relatively few coming in with significant substance use disorders. And those who do have psychiatric disorders, they tend to be on the relatively mild spectrum. Part of the program involves actually, so I'm actually a psychiatrist. I think that was actually misstated in the application. I'm the director of the program. I'm an MD, PhD. But my clinical credential is I'm a psychiatrist, I'm an MD, so I am there as well as other psychiatrists, at least one other psychiatrist there as well, to screen and also evaluate any patient who has a mental health concern and potentially provide treatment if there is a relatively urgent need for treatment, especially if there's some safety concern or expression of suicidality. We're immediately available to assess them and provide that treatment. For patients with milder problems, the idea is this is short-term treatment. It's typically about a 3-month duration of treatment. So the goal is really to link patients with treatment in the long term, right? So again, and also the co-occurring mental health disorders are also included in the treatment as part of the gambling disorder treatment as well. So mild depression, mild anxiety, even mild substance use disorder is managed by the licensed therapists who also have skill in treating those. And again, to the extent that they require medication intervention, the psychiatrist, myself, will evaluate that patient and then make a determination if that's appropriate, and then provide a bridge, again, to a longer-term referral when they're inevitably going to be discharged from the program within a 3-month time frame.
Are there any other questions?
I have another question sort of related to that. Can you talk about who you plan on serving?
Yeah, the age
group. The age group? Right. As the mother of young adults.
Yes.
Who tend to be mild depression, anxiety, and gambling issues.
Yes.
Just wondering, particularly when we think about just the explosion of sports gambling and what's happening, society-wise. Number one, who are you serving? And number two, is there, because craft and CBT are used for a lot of things, obviously, are there any treatment modalities that are particularly attuned to this population and the idea around sports gambling? So just wondering.
Yeah, I think those are both really very good and timely questions. The answer to the first one is, I think, it's simple. We're treating adults, so anybody over the age of 18, and there's no upper limit to that. It would be great if we could expand our services to provide more treatment for adolescents, but we would need to have hire therapists who are trained in treating of adolescents and so on. It's a very specialized form of treatment. And so hopefully in the future we will have the budget and, to do that. We are looking to expand our services and so on. So that's the age range. The second question in terms of targeting treatments towards online sports gambling, right? I think that's your.
Well, I think just gambling in general
Gambling, right,
versus,
Sure.
any other addictive.
Yeah, so I think you're correct to note that CBT and MI are in some sense generic treatments that could be used to treat substance use disorders, for example, or depression. But the form of CBT and the form of motivational interviewing and the form of craft that we use is actually tailored specifically towards gambling. These are manualized treatments. We have a specific kind of protocol that we use in our program, and based on the sort of research evidence that has been probably more than 10 years established around using. So CBT and MI are actually the mainstay treatments for gambling disorder. There's not some other treatment that we're aware of that is like more effective, at least in terms of individual psychotherapy. Craft is another treatment that, just for those who are not familiar, it's a family-based intervention where the actual target of that intervention is the concern significant other people, right? We're actually very unique, I think, in offering this particular modality for people with gambling disorder and concern significant others. Often it's just the focus is the identified patient, but really a lot of the need in the community relates to parents, who are coming in and saying, my son's got a gambling problem and he's not all calling, right? But it's the parent who's like, what do I do? So this is focused on helping the family member, the concerned significant other, to essentially motivate that identified patient to enter treatment, and then once they enter, to actually, sort of support that treatment, and then sort of help to channel motivationally the identified patient, sort of throughout their treatment. So the treatments are very much focused on gambling disorder, although they are adapted from the more generic treatments. So hopefully that answers your question.
I have a question. First of all, I think for this council, it's good to see a gambling application. We see that far and few between. So I think over the years, this is probably one of the few that we've seen. But my question is around funding stability.
Yep.
And I'm assuming you need certification in order to bill? Or
That's actually an interesting point. So we, because we are a part of the New York State Psychiatric Institute, right? Which was established as both a research institute of psychiatry, so it's an OMH. This is where it becomes very complicated, just so hopefully people don't.
And I'm trying to understand a little bit more why you can't bill.
Of course.
I'm concerned about the funding stability of this project, given the era that we're in.
Yeah. So we're unable to bill for services because we are embedded within a research psychiatric facility, which also has clinical services. But all of those clinical services are similarly, they're not allowed to bill. So they're funded by OMH completely, right? And this clinic is funded by OASAS, although through a somewhat different mechanism using RFMH. The bottom line, so to speak, is that we are forbidden from billing for services, and so all the treatment provided is free, which actually is a great service to the community. Although, I think we often think about equity and how do we kind of, portion this to people who actually need free treatment versus those who don't, right? But we take all time. In terms of its financial stability, I think that's a very important question. I mean, if we're continuously dependent on net deficit funding from OASAS and that somehow dries up, that's a problem for us. So we are actively lobbying OMH and our institute to actually partially fund our program, and that's an ongoing process. What I'm hearing here, maybe in between the lines, is you would encourage us to get that funding, and be a good thing. And I think we will, give that message to the institute as well, and say that our certification agency, heard this idea, but we're doing everything we can to get funding from that side as well. But yeah, that's a little bit of a conundrum, is the fact that you're stuck in a non-billing. We would be happy to do that, and in fact, that's often why people obtain certification. I think in this case, it's more, it's more to.
It's usually how it
Exactly,
works.
it's like,
Yeah.
oh, okay, well, why are we paying certificate? I mean, we're happy to do it, but I think it's more to engage the place as we kind of, make sure it provides care and, sure that quality, although we need to get that deficit funding as well.
Thank you. Are there any questions or comments? If not, I make a motion to recommend approval of this project. Can I have a second?
Second.
Thank you. All in favor, say so like
Aye.
Opposed, abstaining, motion carries. Moving to the next project, the agency is LLC. We've got a new OSA provider, the CA 2025 Series 7. Brian, for the presentation. Again?
We're having a hard time hearing you. Is that,
We're having a hard time hearing. There's a lot of background
have we
noise.
moved on, or are we talking?
You're good. You're
You're
got
good.
three.
You're good. You're all good.
Good to go.
You're
I
all
also
good.
want to hear what's coming afterwards. I just want to make sure that too.
Yes, thank you. Presenting Certificate of Need 254058 Rippling Waters Retreat LLC, and they are seeking OASIS approval to become a new OASIS provider of a 9-bed men's Part 820 residential rehabilitation service program to be located at 1803 Federal Hill 1 in Delhi. Rippling Waters will offer person-centered, trauma-informed care that is grounded in compassion, caring, and acceptance. Services will include individual and group counseling, peer support, family counseling, stress management, life skills training, relapse prevention, vocational supports, medication-assisted treatment, and case management services, also providing referrals for mental health and physical health care services for clients in need. Rippling Waters reports that Delaware County has elevated alcohol-related hospitalization rates, and the county ranks in the bottom third of New York counties for health outcomes and substance use indicators. Rippling Waters Retreat also reported that Delaware County has currently no OASIS-certified residential substance use disorder programs. Counties that border Delaware County have very limited options and are mostly mixed-gendered. Rippling Waters Retreat reports that they would be the only male-specific residential program in a 60 to 90-mile radius. These services will be self-pay. While no commercial insurance will be accepted, the provider will provide documentation for those requesting out-of-network benefits. The Delaware County Community Service Board initially had concerns with the physical sustainability of the program during the initial startup period, the applicant's underdeveloped knowledge of OASIS regulation, as well as concerns that the proposed program would not meet the needs of county residents due to the high costs attached to these services. Because of these concerns, OASIS followed up with the LGU to address these concerns and provided the county with information addressing these concerns, specifically to verify that the provider demonstrated proof of funds to sustain services for the initial 6 months of startup, verified throughout the course of the review, the applicant submitted policies and procedures to the state's satisfaction, demonstrating the knowledge of OASIS regulatory requirements sufficient to operate Part 820 services. Based on this information, the county LGU submitted a recommendation to approve this application. Rippling Waters Retreat was established as a domestic limited liability company in 2023. The membership structure consists of 2 owners, Thomas Jeffries and Laura Menendez. Thomas Jeffries, PhD, reports 18 months of direct experience working in residential drug rehabilitation centers and reports earning his PhD from Pacifica Graduate University in depth psychology with a specialization in integrative therapy and healing practice. Laura Menendez, PhD, LMHC, reports an extensive work history in the substance use disorder field dating back to 2012. Laura reports that she has served as a counselor at both men's and women's specific rehabilitation programs between 2012 and 2017. Through her years of experience, Laura Menendez meets the criteria for an owner with substance use disorder experience. The staffing plan for the proposed program includes a program director, medical director, a clinical supervisor, a registered nurse, a licensed practical nurse, a psychiatric nurse practitioner, vocational counselor, a dedicated health coordinator, and 2 credentialed alcoholism and substance abuse counselors. It was reported that Laura Menendez and Thomas Jeffries will fulfill some of the staff roles pro bono and increase staffing as the census increases. Staff will be on site 24/7 as this is a congregate setting. OASIS recommends approval from the request from Rippling Waters to become a new OASIS provider of Part 820 residential rehabilitation services with the following contingencies. Verification of the hiring of sufficient staff to meet regulatory requirements, OASIS inspection and approval of the completed facility, and a copy of the filing receipt from New York State Department of State indicating that the amended articles of organization, including the OASIS required language, has been filed. Thomas Jeffries and Laura Menendez are present in Albany location. Should the committee have any questions regarding their application? Thank you.
I do have a question about the budget. And my question is, how can you, if you can talk a little bit about that budget for what, $124,000? Is that? That seems very.
Yeah. Hilda, we couldn't understand you.
For the staff. For the staffing. It doesn't make sense.
Doesn't make sense.
I'm not gonna vote for this one. Thank you.
Hilda?
The annual budget, operating expense, 24,000.
Thank you. Thanks, Debbie Ann. Hilda?
Yeah.
We couldn't understand your question, sorry.
Can you talk a little bit about the budget that you submitted? That it's, how can you function on a budget that low?
Did you understand?
The budget's low, could you just talk
Oh,
about the
okay.
structure?
Excuse me. The budget is low because the agency, the center, is on our property. So we've actually built the building 30 years ago, renovated the property. It was wilderness when we got there, all 400 acres, the stables, there's a private lake, the house, so all those property taxes, the heat, everything we've been paying for 30 years already. So the only thing that's really required when we have 6 months with no clients is the staffing. Because if there are no clients, we've been paying those bills for 30 years with no problem, and we have no problem continuing that. And so it's the staffing that is on the low part of the budget.
So just for clarification and a follow-up to that, your staffing plan is very rich, which I commend you for. You have RN, LPN, psychiatric nurse practitioner, vocational counselor, licensed mental health counselor, and 2 BHSACs here. And when I think about those expenses just for the staff, plus their fringe and everything else, $124,000 is fairly low for that richness of staff. And then I'm thinking about your OTPS for food that you have to feed the 6 residents, et cetera. How do you get into an expense of $124,000? I'm baffled by that.
You should explain that
as we stated in the summary, some of those roles will be fulfilled, and they can speak to the roles that they're gonna both fulfill initially. They are not gonna accept a salary, until they are at full capacity. So that's part of the reason why those numbers are so low, but you can speak specifically.
Yes, that is the reason. We live on the property, so we'll be right there. And the OASIS required staffing, can you hear me? The OASIS required staffing really requires the medical director, the psychiatric nurse, and the LPN. But if we don't have any clients, they're still on staff, but we don't need, any of those other positions because we're fulfilling them pro bono until we get up and running. And we only plan on getting 1 or 2 or 3 people for the first couple of months as a slow start. We're not jumping into this blindly or, with that thought. We're going to start off slow. But we have the money in the bank to sustain the OASIS required positions that we're not fulfilling.
So for instance, I am not just the licensed mental health counselor, I am also going to be wearing the hat of the program director and the clinical supervisor. And so that's, and then my husband here would be he would be doing some, like the KSAC, some of the KSAC role, and also the vocational counseling. So, in addition to just counseling and group therapy and all.
But we'll be doing the pro bonos till we get up and running and get clients. But with no clients, there is no food expenses. There is no other of those expenses. And once we have clients, we're going to be fully staffed. We'll probably hire more than OASIS requires because our goal, we always ask ourselves, how do we serve the men best? This is what we're there for. We've been, planned this for a very long time. So that's where those numbers come from.
So the revenues then is inconsistent because if you're starting slow, the revenues would not be so high. How are you projecting $2.5 million in revenues if you're starting so low with expenses?
To be honest with you, I did not put that in there. If we were required to submit a 6-month budget based on no clients, and how can we sustain the business if we have no clients?
But I just want to say one thing, since we've been, working towards this, we've probably had 24 calls from people who are looking for recovery centers for their sons or husbands and so forth. So we can't open until we're certified, obviously, which won't be until hopefully today. And then in January, we can start to call some of those people. And they were very eager to come to our place because we offer different things like the equine therapy, wilderness therapy, a lot of nature therapy, hopefully music and art therapy, in addition to a lot of group work.
But I understand your question, and I think I could best explain it by saying the revenue at full capacity, which won't be that 2.5, because out of the 9 beds, we are donating 1 bed per bono to the county. 11% of our bed space is a gift to the county so we can help our local community. So for the first 6 months of startup, if there are no clients, the money only needed for the positions that OASIS requires to have that Laura and I won't fulfill. If you need me to clarify that in a different way with a metaphor or anything, I would. But I really can't explain it any other way. Once we get clients, we'll be able to hire staff that's needed. But the required staff by OASIS is already taken care of.
So you're saying you're monetizing, you're counting an in-kind contribution of your time and the bid to the county. Did you get a figure for that? Is that an in-kind contribution?
I couldn't understand everything you said.
Sorry, sir, can you repeat that?
In terms of getting to that $2 million figure, did you include your labor and the donations to the bed, to the county?
Yes, that's included. That is, I believe that's included in there. And let me also say that we're not asking for New York State for any money. We're self-funded. We built this property from scratch. In the last 3 years, we put $1.3 million into the project. And I also have to add, 35 years ago, I was homeless. I had a drug addiction. This came from McDonald's, saving, working, sacrificing. We bought a building and then rented to students in a college town, bought another one. This has all been a plan for us to get where we are.
So can I just ask for clarification then,
Yes.
probably from OASIS first? Because what we're seeing in the document is that there's a revenue of 2.5 million with only an expense of 125. So is it what you're saying is that the 2.5 million in revenue, that's when you're fully operationalized, the full annual, and the 125 just represents startup expense, and so these are not exactly apples and oranges. I think
I can.
Always can confirm that, that'll be helpful.
Yes, that makes sense, but let me jump in that fruit basket with you, with the apples and oranges. That 124, if you looked at our full application, you would see our P&Ls that actually says when we have full people, our expenses are $867,218. That includes our compensation, legal, accounting, advertising, bank charges, credit card, book, insurance, rent, meals and entertainment, room and board, property taxes, supplies. Those things weren't really included in the 6 months that you're looking at.
So I think that's helpful to know, because
Yeah.
we're
Yes.
just,
But if you see our budget-
we're not seeing just seeing 2.5 and 125,000.
Right.
Right, I got that, but I thought that you had our full
No, we do
pages
not.
of application.
Yeah, we do not. We do not.
But the profit and loss thing, we didn't jump into this blind. The profit and loss, that was helped with Sam Cardell from the Small Business Association out of the local bank. We went through this with a fine-tooth comb, and the expenses, are the same regardless of how many clients we have, which are considered, it's almost $1 million in expenses, 867 to 18, which is probably, pretty accurate. We had some financial people help us. The
And that makes a lot more
124
sense.
Yeah.
Yes.
Yeah,
The
that makes
124
sense.
The
That makes
124, I
sense.
believe
Thank you.
Ryan came up with because he said, right, 6 months when you have no clients, we're pro bono, no food, we're paying all those other bills, and the staffing that Oasis, Dina, and Brian required to us, we have that included in the budget.
Got it, thank you very much for clarification.
That makes sense.
So let's do approval, since we still have 2 more projects to go over. I make a motion to recommend approval of this project, and I second.
Second.
All in favor, say so by saying aye.
Aye.
Oppose, abstain, motion carries. Thank you very much. Now we, the next
Yes.
the agency
Through the second. The whole council has to vote on the recommendation.
the new Oasis provider. And I don't have this here. Brian Brandy will be presenting once again.
Good luck to you guys.
Brian?
Thank you.
Yes, thank you. Certificate of Need 254047, this is Rockland Recovery Homes. They submitted a certification application requesting the New York State Office of Addiction Services Support's approval to become a new Oasis provider offering Part 860 recovery residence services to be located at 328 Willow Grove Road in Stony Brook, New York. Rockland Recovery Homes reports that the home operates on NARR Level 2 standards for recovery homes. This includes a home environment monitored by a house manager, the establishment of house guidelines and rules, and an appointed resident leader. This home currently employs 1 staff member, which is a house manager, and Rockland Recovery Homes encourages attendance at self-help meetings and requires all residents to attend outpatient treatment until successful completion. Please note that residents do have an independent choice of which outpatient treatment provider they wish to attend in the community. Furthermore, the house holds meetings to include issues that occur in the home and the progress of each resident's recovery. Residents pay rent at $700 a month, which includes utilities, TV, internet, phone services, linens, laundry detergent, cleaning supplies, first aid supplies, and the maintenance of the residence. Rockland Recovery Homes reports that an increasing number of people who enter recovery are in need of a recovery residence option to increase their chances of successfully living a sober life. It was reported that there is a lack of recovery residents in the lower Hudson Valley, which is confirmed by the number of requests received by Rockland Recovery Homes, often leading to a wait list. This application has the support of the Chemical Dependency Work Group in Rockland County, the Rockland County Department of Mental Health, and the Oasis Lower Hudson Regional Office. Founders Stephen and Claire Clement found Rockland Recovery Homes as a domestic not-for-profit corporation in 2018 after their son Paul passed away from a drug overdose. They believed his passing was due to an absence of a safe, stable, and supportive recovery home. Mara Mendocino is a board member of Rockland Recovery Homes and is a BHSAC Level 2. Mara reports a history of providing substance use disorder services since 2005. Her experience includes counseling at Nyack Hospital, the Mental Health Association of Rockland County, and Lexington Center for Recovery. Furthermore, Mara reports that she is a qualified OASIS trainer specializing in problem gambling. Through her years of experience in qualified healthcare professional status, Mara fulfills the OASIS requirement for a board member with recovery experience. The staffing plan for the proposed location meets regulatory requirements and includes one full-time house manager. Policies and procedures have been approved by the Bureau of Recovery and meet regulatory requirements. Rockland Recovery Homes reports that they utilize a community resource binder for residents in need of additional services. This binder includes information on local service organizations that can assist in supporting a resident's recovery. The house manager is able to assist in connecting residents with finding and utilizing these resources. OASIS's recommendation is to approve the request from Rockland Recovery Homes Incorporated to become a new OASIS provider of Part 860 Recovery Residential Services with the following contingencies. Copy of the filing receipt from New York State Department of State indicating that the amended certificate of incorporation, including the OASIS required language, has been filed, and verification of the hiring of sufficient staff to meet regulatory requirements, which since the time the application was submitted has been satisfied. Although Stephen Clement, CEO of Rockland Recovery Homes, is not able to be in attendance today, I do welcome any questions the committee has to the Bureau of Certification or the Recovery Bureau present in the New York City location. Thank you.
Any questions?
Yes, I do have a,
Go ahead, Vivian.
the 328 Willow Grove Road is not in Stony Brook, New York. Is that
That's the
Stony
same question,
Point?
yeah.
Stony Point.
It's Stony Point, not Stony Brook.
Upstate Long Island.
I have another question, and I apologize, I didn't see it in here. Can you talk a little bit about program capacity?
I could speak to that. Yeah, so the capacity is 8 beds. They're mostly filled. As of September, there was 6 filled with 1 pending. They do have 6 bedrooms. 2 are double, 4 are singles, but the capacity is 8 men.
Okay. Can I ask a follow-up question to that? Residents pay $700 per month. What do you have in place for residents who are not able to afford $700 per month?
So most of them are self-pay. It's a good option for them compared to local rents in the county. About half of the residents are employed. The other half are in intensive outpatient. There is not funding directly from OASIS for recovery homes at this time. There is a one-time RFA for enhancement, but the residents are mostly self-pay. The rent is very reasonable is what the understanding is. And the operators traditionally from recovery homes can work with residents with payment plans and basically leniency if they become unemployed. There's usually a payment plan. They're not evicted or anything like that. So there's essentially flexible the self-pay portion for the $700.
Any other questions?
So,
Yeah.
let me just, so it's geared toward a certain type of individual who can pay, right? So this is an option for someone who has the ability to pay. But I know that Stephen has individuals that have not had the ability, maybe they lost their job, and he is able, because he has some funding on the side, to continue to be able to house them. So there is a cushion with what he works to be able to continue to support them until they're able to get another job to be able to support the rent. But this level of care is a level of care where people are expected to typically pay rent.
I have a question.
And just to follow up to that, I'm going to put it on the table because recovery home, these are services that people across the continuum need. And if there's a need, we should be thinking broadly, and that's not to you, it's broadly, how we're going to be able to support everyone who needs this kind of services.
Similar budget question. Can you confirm, because we have that your total revenues is 67,300 and expenses at close to 25,000. Can you explain what you counted towards as expenses? Is this a building that is being housed solely for the use of this program? Is it being?
It's a house, so it's a house.
It's a single-family house.
And a single-family house, the mortgage is already paid off on this house. This is a gentleman who lost his son due to overdose and wanted to give back. So he has his home that's already mortgage paid, so he goes.
I can speak a little bit more, yeah, so the 24,000 basically breaks down to property insurance, utility and service bills, maintenance and upkeep, furniture and other minor expenses. So it's not a high expenses because he doesn't have a regular mortgage payment or, it's a single family home with 8 capacity that he has to maintain. He's had the property for quite a while.
And he's not providing food for the individuals. They're responsible for their own
Correct.
food.
Correct.
They have spaces
That's
where they
food
go.
alone.
Yeah.
No,
They have
provide their-
spaces where they can keep their food, their own groceries.
Right.
They do their own cooking. This is a residence. This is their home. So it's a home-like environment. This if they were in their own.
Just as a quick question, it sounds like a wonderful model. I would imagine people wouldn't want to leave. So is there like a length of stay requirement?
Yeah,
Like, how are you?
I can speak to that. So our regulation 860 does not have a length of stay requirement. It's usually according to the resident's recovery journey. I will say the average length of stay is about 2 years. That doesn't mean when a resident hits the 2-year mark that they're automatically asked to leave. It's evaluated on a case-by-case basis, where they are in their recovery journey. Usually a plan is worked towards independent living. There is no exact length of stay, but it averages about 2 years.
It's past 12:05. We still need to present another project. Is there any other questions?
Just a quick comment, if I may. Hey, Debbie Ann,
Yes.
let's raise that question that you raised at the full council this afternoon.
Okay, will do.
Okay. So I will make a motion to declare for this project. Can I have a second?
Second?
All in favor, stay so by saying that.
Aye.
Opposed? Abstaining? Motion carries very much. Thank you very much. We have the last project, and this is San Xavier Care Services, the agency. They are a new Oasis provider, and the CA 2025-042. And represent this project.
Good morning, everybody. This is for San Xavier Home Care Services, Inc., doing business as San Xavier Community Services. Again, application 2025.042, con number 254024. And this is to become a new Oasis provider for Part 822 Comprehensive Outpatient Services. I believe there are some representatives from San Xavier in New York City. I think Mark Raymond actually specifically is there, so they can come to the table. They'll be able to answer questions. San Xavier is seeking approval from Oasis to become a new Oasis provider of Part 822 Comprehensive Outpatient Services at 108-18 72nd Avenue, Forest Hills, New York. The proposed facility will operate from 6 a.m. to 2 p.m. Monday through Friday, with dosing hours 6 a.m. to 10 a.m. Additionally, The facility will be open on Saturdays from 7 a.m. to 10 a.m. The program will offer a variety of services, including assessments, evaluations, intake, individual and group counseling, family counseling, vocational counseling, and medication-assisted treatment. St. Xavier is a domestic business corporation that was founded in November of 2013. This corporation operates under 3 different trade names or DBAs. St. Xavier Durable Medical Supplies, established in August of 2018. St. Xavier Community Services, created in December of 2018. And Madison Community Services, which was filed in February of 2025. Currently, the ownership of the corporation is divided among 3 individuals. Christina Bella Corcoran, who holds 70% of the ownership and voting rights. Janine M. Kramer, who holds 20% of the ownership and voting rights. And Amit Mala, who possesses 10% of the ownership and voting rights. Janine M. Kramer, who is a 20% holder in ownership, has been found to meet the OASIS regulatory requirements concerning substance use disorder experience. The organization currently holds licenses and certifications with the New York State Department of Health, New York State Office of Mental Health, and New York State Office of Child and Family Services. These certifications have been verified through their respective governing agencies and are in good standing. The proposed annual budget estimates total revenue at $349,760, which will be generated from Medicaid fees for services. Total expenses are projected to be $349,600, covering salaries, fringe benefits, professional services, property expense, and general overhead. This results in a total profit of $160. Additionally, the submitted budget included $70,000 in pre-operational expenses, which was covered by the applicant. The New York State Regional Office reported no concerns after reviewing the submitted budget. The applicant has provided the required documentation demonstrating sufficient funds for the first 6 months as the program gets underway. The OASIS Fiscal Audit and Review Unit also conducted a fiscal viability audit and determined that the applicant is fiscally viable. The New York City LGU and the OASIS recommend approval with the following contingencies: verification of hiring of sufficient staff to meet regulatory requirements, final review and acceptance of policies and procedures, and copy of filing receipt from the New York State Department of State indicating that the amended certificate of incorporation, including the OASIS required language, has been filed. And now I think Mark's there for any questions.
Are there any questions or comments?
I have a question, if I may. The hours of operation are a bit different than we usually see. If we could talk about the hours of operation and how that lines up with the services that are being suggested?
Can you please repeat that question?
Oh, sure, sorry. The hours of operation are somewhat different than we typically see in these applications. So if you could talk about the hours of operation and why they are, in a sense, limited to the morning hours?
The morning hours are going to be focusing mostly on medication administration and counseling services. And so when we first start up, we're going to be providing dosing in the morning hours in addition to the additional counseling services. As we expand, we can add more hours into the afternoon. Saturday is going to be mostly dosing only, for medication only. Of course, we'll have staff in case there's any emergencies or situations. But we'll expand hours as we continue to develop and grow the program.
Any other questions?
So you're focusing really on the medication-assisted treatment is what you're really focusing on right now.
That's a very big piece of it, but we really do want to be able to offer all of these services. But the medication administration, that's the most complicated. You know, we need to have the DEA, we have to have SAMHSA, we have to have OASIS all involved. We're going to have nurses on site that are administering the medications. But we're going to be providing, that's why we apply for comprehensive outpatient. We want to be able to provide all of the services. So even if a patient doesn't have an opioid use disorder, we still want to be able to work with them and help them. But, you know, the opioid treatment with the MOUD is the most complicated pretty much the most evidence-based for saving lives.
And so what you're describing is really an adult population, or, because I'm just looking here and it talks about the mental hygiene services plan, a goal of improving interventions for children and youth, but what you're describing sounds like an adult population.
It is definitely predominantly adult population. You know, regulations do allow you to work with adolescents with opioid use disorder, and the regs have actually, subsided a little bit, become a little bit less restrictive. But we do not see a lot of people under 18 coming in for MOPD at this time.
All right, so you're really serving more adults.
Mostly adults, yes.
And what do you-
St. Xavier does have a lot of experience working with adolescents, so if that becomes a situation, we'll definitely be able to modify.
And what do you see as your capacity?
That's a little bit of a wild card in terms of how much we're going to see, but as far as capacity, we think we could treat up to 400 or 500 patients in this one location. We have 3 dispensing windows. But we'll start small and we'll build up and we'll adjust as necessary. We're not exactly sure how many people are going to be coming through the door this time.
So to piggyback on that question, can you walk us through again a little bit of your budget, and does your annual budget expenses are expected to only be $349,000?
I'm going to have to pass the budget questions to Mr. Mitchell.
Okay. Well, I looked at doing the development, we were building, I built everything out, and I looked at the numbers closely, and right now we're at a budget of $2.7 million.
Thank you. Are there any other questions? If not,
Yes, I just have a follow-up question to that. So this 300 is the startup, you're saying, but your full annual budget is 2 point?
Right.
Okay.
2.7.
Oh, that makes sense.
Makes sense.
Yeah,
We look
yeah.
at a monthly expense of $232,000. Especially for the first year, we're not planning to see a profit in the first year.
thank you. Thank you very much. I will make a motion to recommend approval of this project, and I have a second.
Second.
All in favor, stay so by saying aye.
Aye.
Opposed? Abstaining? Motion carries. The presentation of the different projects, Mike will present to the full council this afternoon, and wish everyone a happy day. Thank you very much.
Did you include remind you of questions were asked? I remember. I will write it down. So tell me to put that in. Any more? No. All right. Okay. So you don't need anything. Yeah, okay. Remember we used to put down the questions if it were how many go right down? You did? Okay. I just want, it's been so long since I've done this stuff.
Sure, so we get started now. Glenn is just getting himself ready. Should we begin?
Yep, sounds good.
Okay. Is that Glenn?
Yep, sounds good.
Glenn?
Yeah, I think I'm warning you there, okay? You have to tell us.
Oh, no. Is that Glenn behind it?
Glenn out there?
Much better. What you look at the front.
Powdering his nose.
Glenn is just doing makeup.
Hair and makeup.
So we're all set.
Yeah, we have a
All
quorum
set.
too.
We
have
have
a
a
quorum.
quorum.
Excellent. Great. So do you wanna?
Do you want me to? Do you want to?
Yeah,
get lunch?
good.
Okay. Pat, I guess we'll get started. Glenn has joined us. He's just settling in. We gave him his lunch, so he's nourished and hydrated.
Powdered his nose.
But
We're all
he's
good.
asked me to just begin the meeting, the full council meeting. So again, thank you everyone for joining us. We did want to start with our committees that met this morning. We have the Treatment Equity Committee report, the Regulations Committee report, and we had 10 projects that we reviewed as well that we'll cover. So if it's okay, we'll start with the Treatment Equity Committee report for the full council.
Thank you, Michael. Debian, would you feel comfortable
Hey, Shaku.
providing the report? Good morning or afternoon, everyone.
Good afternoon, Shaku. Yes, I will. Thank you. So good afternoon, everyone. The committee met this morning at 9 a.m. And during our meeting, we had a presentation from Tibby, who is the, help me here, she is the Diversity and Equity Officer at OASIS. She presented to us the modernization project that is currently being implemented by OASIS to update their technology. And the goals of the project is to reduce provider burden, their ability to evaluate data. According to Tibby, and what the field does know is that data is fragmented and it prevents holistic evaluation of services across systems. Another goal is to remove multiple manual inputs, thereby decreasing duplication of data entry. They're reviewing demographic data categories as the needs change so that they have a system that is flexible to adapt as needs change. We will be able to use data to determine who is getting care and what services are needed in different regions. The timeline for this project is not clear. That was not discussed with us. She doesn't know. They're currently in phase 1, which is an internal analysis of OASIS's technological needs. They will move to phase 2, which is technology procurement, and thereafter they'll have several steps that they will take, different phases. We ask about plan for provider involvement, and there are no plans at this time, so we made a recommendation for the next step for providers to be involved so that provider can the field can provide information as to how the data systems should work, what needs to be evaluated, and what upgrades need to be made to ensure that clients are getting holistic care. The next steps in the modernization project, we ask that Oasis be strategic in the type of reporting and also in the way they're thinking about this upgrade. And of course, to include providers in phase 2 before any procurement of the technology. The next steps for our committee are we will get updates from TIBI frequently where the process is and how it's moving forward. We will have a strategic discussion with DOH, OMH, and OASIS about data exchange to facilitate better patient outcomes. That is, how can data be exchanged across all agencies and more of an integration of the data systems, considering OASIS is in this process. There was discussion among committee members that we will be reactionary to the governor's proposed budget by the time we meet again. Our goal was to provide proactive guidance, our input into the budget, but because of timing, we won't be able to do that. But we will be reactionary to the proposed budget, and hopefully some of our suggestions can get incorporated there. And also, we discussed an invitation of OMH's diversity officer to our next health equity meeting and subsequent meetings, as this is not mandatory, but we would like for OMH to have representation there as well. Did I do a good job? Okay, you can add what I omitted.
Thank you.
Any questions?
Debbie Ann, I know this, I'm sure you didn't discuss it in the committee, but is this a good opportunity to talk about the recovery homes issue that we mentioned earlier?
I think so.
Yeah, I mean, unless we're going to do the projects review, we can also include it in that discussion, Dave. So whatever you feel is best. But I definitely wanted to bring that up, and we also wanted to just recap the OASIS budgets moving forward, because that was a big issue.
Yeah, I'll leave it to you, Mike. Yep.
Okay, why not?
Well,
Go ahead, share. What?
So I think that the question, and it may be one of not understanding all of the nuances of it, but there is a level of care that OASIS certifies called recovery homes that require the people living there to come up with $700 a month in rent. I'm sure that works well for some segment of the population. There's also, my guess is there's another part of the population that doesn't have $700 a month to be able to participate in that level of recovery that they need, and that seems to me to fall into the discussion around equity. And is that then fair to all of New York's citizens that level of care is functionally, at least, not available to the poorer individuals among us?
Yeah,
Fair to say, Debbie Ann?
correct me if I'm wrong, this
Yes,
is a
you got it
relatively new, the Part 860 regs for recovery homes is fairly new, correct?
It's fairly new, and the history of it really was about, and again, this is my understanding, I could be totally wrong, but OASIS does not provide funding to this level of care, either as a billing capacity or a deficit capacity. And the history of it really came about where these homes exist. And there were a lot of back and forth, not so good stuff happening, stuff that ended up happening that, you know, it sort of painted the picture of addiction residential programs doing this service, and it really wasn't. It was private citizens just providing this. And there was a request from the provider world to have OASIS certify these programs. So the certification of these programs
On a
is
voluntary basis.
on a
Some-
voluntary
yeah, not all of
basis,
them
not
are.
everybody has to, so people can continue to run these homes and don't get certification.
Exactly.
And it was an outcry from the provider world to get some sort of certification, at least, at the bare minimum, if not funding. And that's where this came about. So I think as now that they've done the certification, if there needs to be a rediscussion with OASIS as to if there is any financial plans on their part to address the inequity situation, I think it's, you know, it's a good conversation to have. But the history of this coming about was really about these homes existing in the state of New York, as they do in other states, and they're not certified.
How many are we talking about?
Excuse me?
How many of these homes are we talking about?
That's a good question. I don't know.
This is the first that's
I mean, you could go to your local church and your local church might tell you they have a house that was donated by Mary Jane and the house is now being used for
We have several in the Mid-Hudson region. We have one or two Westchester that are not certified, and their Oxford House is a big provider. And some of them are now getting some opiate settlement funds from counties to support them. And the $700 rate, that's a rate that Rockland Recovery House came up with. It's not standard or universal. Some do other sliding scale or, so I think this is the first one we've ever had in our projects.
We had another one that was $1,000, but they have one room that was for people who are uninsured. That's the if you go back and read the
So there's no
design.
like overarching guidelines about how you do this, and
That's the one
funded
on the farm.
On the
what are the standards?
Well, the certification has some of that, but not
Right.
real funding requirements.
And,
Dr. Reagan, I wanted to weigh in.
If the number is correct, was, wasn't it an issue of standards and?
Yes.
Living condition?
living conditions
Sober house.
and what has to happen within these homes, and it was, you're absolutely right, Joe.
So
You're
are they
right.
regulated now? Are they?
Yeah.
Voluntarily.
apply. If you apply.
We have one in our county, they charge $10,000 a month, but they're not certified. It's beautiful, it has a gym, a shower, you can do it, but it's not certified. They are not gonna be, they don't want to be certified.
Certified, right?
We should be taking action. I mean, I don't want to preclude, because I guess there was already discussion of this, but is there an action we should take on this? You know, should we send a letter to the commissioner? Should we be doing so? I don't know. Again, I'm coming in late to this, so I don't know what already has been discussed.
It wasn't discussed. It was a question I raised during the project review. But I do believe we should take an action. It's something that OASIS should pay attention to, because if they're certifying, then at least I would hope that there is some equity there. And, you know, is it a proportion of the beds, or is it some financial assistance for, you know, someone applies and they can't afford to do it, use some funds put aside.
Yeah.
But there should be an action.
Right. To further Debbie Ann's thought and David's thought about this, an option for a recommendation could be that now that we have the regulation in place, might there be a guidance document that be developed that really sort of give folks the guidance around establishment of these things, which will encompass this equity question? And it's not unheard of. There are other regulations that have guidance documents, accompanying guidance documents.
And to add to that,
Sorry, our hand is up. We've been trying to jump in for a little while now, so I apologize for interrupting who's talking. I love the idea of trying to create a guidance. I just want us to also be just aware that not all recovery housing is required to apply for this voluntary regulations. That's through OASIS, from my understanding. And if we don't have funding, then OASIS is really not going to be able to get a hold of how many of these recovery houses is really out there. In addition to that, some of the recovery houses, and we have quite a bit upstate in Marlborough County, some of them are getting congregate care, some congregate care dollars to help offset some of it. And then depending on how big the house is and how many units each house has, is going to dictate how much that resident has to pay. And then some residents are applying for DHS funding for rental assistance. Some here are also have SSI or SSD, and so they're using some of that. And some of the participants are also working. So yes, I do think a guidance will be helpful, but we also want to make sure that guidance doesn't push people from not wanting to apply for this
Correct.
the regs
Yeah,
as well.
true.
But I don't disagree.
Yes.
Just
and a guidance is just that. It's just to guide the process. Yeah.
if I can add, in addition to that, this is separate from the guidance, it's really just trying to understand the full ecosystem. Like, what is that care continuum, and, you know, what information might OASIS be able to share with us based on the information they have, which may be limited, but it might also be helpful just to understand what is available within our communities as a part of that continuum of care, which some people may access, some people won't. But it would just be very helpful.
Any other questions or comments? All right, our next committee report is the Regulations Committee report. Patrick, I'll turn it over to you.
You guys hear me, right? Okay, so we only have one regulation to review today in the Regulations Committee. It's Part 810, which is the establishment, incorporation, and certification of providers of addiction services. The majority of it were grammatical changes or changes in language, and big framework for this is really OASIS, aiming to align its current practice with its regulation. There were just a couple of areas that we really had extensive discussions about. One was the governing authority, the area that is highlighted, and just making sure that, just some clarifications around, sponsors or, bodies that have authority over providers and what that means, depending on their agreements and bylaws, what kind of control they have over the provider. So really just that understanding that, this regulation doesn't require that they have these rights over the smaller organization, but that if these things exist, then they have to go through the process of becoming a certified sponsor if there aren't already a certified sponsor rule. The second area that we really discussed were 810.5 and 810.6. Just understanding, when a full review is required versus administrative review. And I think in the end, right, the understanding was that if a sponsor is unknown to OASIS, so they're a new sponsor, not certified, then that has to go through full review. And if they're already a certified sponsor, then OASIS already knows them, then that's more of that quick administrative process with OASIS. Another area was that changes with these regulations is going to a 3-year operating license for providers, as opposed to what had previously been the practice of, depending on the review, providers getting a 6-month, 1-year, 2-year, 3-year license. But more so now that the license is 3 years, and the corrective action plan from the review can be monitored, based on what's written in these regs, between Oasis and the provider. Right, not the regional office, but monitored by central office. That was pretty much it. I think we were able to get, with our discussion with the Oasis representative, all questions answered and clarified. Like at this time, I'll open it for if there are any questions from the general counsel that most likely the Oasis will need to answer as opposed to me.
Questions? Any questions, comments?
The only, just one other comment, and this doesn't relate to the OASIS regs, but I know that we had reviewed some potential modifications for the motors this summer, and I was just curious if, from an OMH, and I was just wondering if there's any updates on some of that. That anyone has heard.
I heard anything. Do we want to go through the process of approving these regs and then go into Warren's question? It's a good idea.
Yeah.
So,
was there a question on 810, part 810 for Oasis?
yes, I do have a question. And I don't know if this was discussed, but there was mention that merger, space expansion, and transfer of ownership would go to an administrative review. And I just wanted to hear if the committee had a discussion about merger going to an administrative review.
Yes, that was included in the discussion. Mainly that if it's between already certified Oasis providers or already certified sponsors, that it's appropriate to go through the administrative review versus entities that are not yet certified or known to Oasis.
Even for mergers?
Correct.
Oh. Thank you.
Right, my Oasis friends, I'm answering correctly?
Yeah, so with a merger, we have 2 known Oasis entities. So that's where that's the situation we're talking about there.
And it sounded like you also had some subjectivity around your review process, correct? Like that you would be individualizing those reviews accordingly.
Jaco, can you say that again?
Yeah, it just sounded like there was also some, opportunity to be able to review those. I guess it doesn't matter. It's really about the administrative review versus full review. So never mind.
I think Debbie Ann, maybe someone who asked this question, right? I can't see too well.
The reason I ask, because mergers are a little bit different, and just to get a full understanding of how, why, when, where, sustainability, et cetera, when mergers are involved, it may need a little bit more than an administrative review. But again, I don't know what that process is going to look like, if there will be changes in that process. That's.
So in an application requiring administrative review, that's where we have a merger between 2 known Oasis entities. Both entities are certified.
All right. If
Okay.
possible, we'd like to move forward with the project review committee because we have several to cover, and Commissioner Cunningham is here joining us, and we want to be respectful of everyone's time. So is that okay that we move with the project review?
Yep.
All right, and
As
I'll
long
try
as,
to be really.
as long as it's fine, just
Oh, I'm sorry.
Can we have certification chime in with some helpful information?
Just a point of,
Clarify.
important point of clarification, I think, to your question about mergers. So a merger application, which falls under an administrative review, just so everyone understands, it is still a full certification application that goes through the same level of review of all of our applications. The only difference is that that application is not brought forth to this group, because as we just explained, it's two existing OASIS providers. The reason it's in the regs now, honestly, is because it should have been put in a long time. We've been doing this type of review with mergers for years. We noticed that we didn't list that as one of the application types for administrative review in the that were written. So we're including them now. They should have been in the previous set of 810s that we did, but by no means is it not held to the same criteria and standards to be met in order for approval. It's literally the only difference is it's not just brought to you all at this type of
Thank you.
Patrick, do we need to take a vote on this?
Yep, we'll put this up for a motion to vote.
Second?
All in favor?
Aye.
Anyone opposed? You want to abstain? All right. Regulation Part 810 is approved by this committee.
Thank you, Patrick
Thank
and
you.
committee, appreciate it. So I'm going to kind of move quickly through our projects. We have 4 from OASIS, 3 are capital, and 6 from OASIS. And again, I want to thank the OMH and OASIS team for presenting the projects. The first project through OMH is Rising Child Center to establish a new program, CFTSS, Children Mental Health and Rehab Service, to be located in Spring Valley in Rockland County. They will serve children, adolescents, and adults 18 to 21 years of age. They are a new OMH provider. Staffing patterns were appropriate. They plan on serving 200 individuals. And the budget also met all requirements and were in line with expectations for this program. Let's see. This was originally submitted under a different organization, which is called Legato. If I'm pronouncing that correctly, it's an established under the Religious Corporation law. And during the application process review, the agency established Rising Child Center, which is a different entity structure that meets OMH regulatory requirements for licensure. Any questions from the full board on this project? Hearing none, we're moving forward for a vote. Can I have a second? Second. All in favor? Aye. Aye. Anyone wish to abstain from voting? Any opposition? Okay, motion carried, project moved. The second presentation was a capital project through St. Luke's Roosevelt Hospital, Mount Sinai, Morningside. This is for capital project to increase capacity for their CPEP down in New York City. Historical utilization has been quite high for this program. It's for adults. And the expansion will allow space for both the CPEP, square footage increase from 970 to 3,622 feet, allow for clinical space, for extended observation beds, total capacity of 5 beds. It met all the approval and conditions. It'll be done in 2 phases and will remain operational throughout the start, which is expected date of January 2nd, 2026, and the goal to complete by April 30th, 2027, with the estimated cost of $7.9 million, which the agency was able to pull together. There were some questions that were asked by the members of workforce issues, adding 48 staff, And the agency talked about doing it in stages and working with temp recruitment as they phase in the project. That was really the only question from the committee. Any questions or comments from the group? Hearing none, I'll make a motion to move the project forward. Can I have a second?
Second.
Thank you. All in favor, please say aye.
Aye.
Anyone wish to abstain from voting? Any abstentions? Any opposition?
I think you had an extension.
Oh, we did. Oh, yes, I'm sorry. So the extension. We have one extension. Thank you.
All right, come back now.
Anyone opposed? Hearing none, project moved. Thank you. The next project is from, again, OMH Columbia Memorial Hospital. This is for capital renovation up in Hudson, Columbia County. It's an adult expansion of inpatient by 20 beds across 2 floors, including 6 single occupancy and 1 double occupancy for a total of 8 beds. All the work is being done simultaneously over 6 months, no disruption of services, and it'll expand their dining room, other rooms, and nurse stations, so it helps them build the needed capacity. No outstanding questions from our project review committee, so any questions or comments from the full committee? Hearing none, I'll make a motion for a vote. Can I have a second?
Second.
Second, we have a second. All in favor, please say aye.
Aye.
Aye. Anyone wish to abstain from voting? Any opposition? Project moved. Our final OMH project is St. Barnabas Hospital in the Bronx. Also capital project to increase inpatient capacity from 49 to 72 adult beds. This is involving 4th floor renovation, new adult psychiatrically, where they're moving their SUD program to the 6th floor. And this work will begin in 3 phases in May of 2026, with expected work of 9 months to be completed, and fully operational 72 beds by October 2028. We did have questions as a project review about the impact of the relocated Oasis beds, and the agency said even with the decrease, it's still above the current utilization rates. That was the only question that was brought up by the project review committee. Any questions from the full committee? Questions, comments?
I just want to comment, Mr.
Please.
That it's nice to see this sort of, these last 2 applications, Columbia Memorial Hospital and St. Barnabas, actually increasing inpatient hospital beds.
Absolutely. Absolutely. And some creative work done by the hospitals as well, really trying to maximize space, and yep.
And it's clearly something we talked about after COVID, bringing these beds back. So it's really good to see the hospital stepping up. And we had even inquired about what was going to happen during the transition with the addiction stabilization beds. And that's also provided within the setup that they're going to be doing at St. Barnabas.
And I know you weren't here, Glenn, but we did acknowledge to the hospital representatives that, yes.
Yeah.
And to OMH.
Yes, absolutely.
So bringing back those beds.
Yeah.
Okay, I'll make a motion for vote. Can I have a second?
Second.
Thank you. All in favor, please say aye.
Aye.
Any abstentions? Any opposition? Okay, project moved. We'll get quickly into our OASIS projects. Again, we had 6. One of the important reassurances from OASIS staff was that moving forward, they have approved to provide the full budget details as we requested. So that'll be helpful because there was some confusion in 2 of the projects, but I think after discussion, everything went fine. Our first project is the AMMGW Full Circle Wellness, a new OASIS Part A22 outpatient SUD service. located in Staten Island, Richmond County. They will do assessments, individual groups, psych evals, and MAT. Their staffing met all the compliance, as did their budget. This program will serve 80 individuals and focusing also on transition age youth as well. One of the points noting of the agency is that they're also connecting with the social care networks as well. That was pointed out by the committee. Any questions or comments for discussion? Okay, hearing none, I'll make a motion for a vote. Have a second?
Second.
Second, Carrie. Thank you. All in favor, please say aye. Aye. Anyone wish to abstain from voting? Any opposition? Hearing none, project move forward. Thank you. Our second presentation is for Professional Counseling Services, Inc. This involves a change in ownership of a Part A2 outpatient services located in Onondaga County, New York. They are currently 3 partners who are selling to Augustine Cochillo, a licensed social worker who will assume full ownership of the project. They were in compliance with all the local LGU and OASIS expectations with some pending recommendations. Otherwise, no questions or issues brought up by the project review committee. Any questions or comments?
I just have a quick question, and sorry if I missed it.
Please.
New owner is the current OASIS provider?
I think.
Good questions.
Well, he operates.
Yes, he's a licensed social worker. He actually operates currently at Treatment Solutions in South Florida. We talked about the division of the 2 services. He claims they're 2 separate entities. And OASIS did confirm, I guess he met their criteria as well for being considered for ownership. That was the extent. Doesn't appear that he has any current OASIS programs within New York State. In New York, exactly.
So that's a provider then that's going through the new sponsor process with OASIS, or they already did?
I missed that. Did you hear that?
I didn't hear.
Can you repeat
Can you
that?
repeat that? I'm sorry, Pat.
Is this a provider that's going through the new sponsor process with OASIS? Or they already did?
No, so the entity, professional counseling, the certified entity, is now being purchased, if you will, by this individual, Augustine. But the professional counseling entity is staying the same. He is just the owner of it now and will be operating it versus the 3 people who owned it previously. It was a stock purchase that initiated that. It's not they're not a sponsor. Actual owner now of professional counseling, and he will be operating it.
Yeah, the service will remain the same.
Correct.
Patrick, does that answer your question?
Gotcha. Yeah. All right. Gotcha. Thanks.
I had a quick question. So has this gone through the full review? Or is this
is the full review.
So this is the full review. Okay.
It gets confusing because our definition of change of ownership is within the existing company when the people change, right? So the company stays the same. It's just I sell it to David, and
This is
David
a
now
perfect
owns it.
example of the conversation we had this morning.
Right. That's a little bit why I'm confused. So do administrative actions come in front of the BHSAC?
No.
No.
No, and a change of ownership would never be an administrative action. It's always a full.
Right. Just trying to clarify. Right. Okay. Appreciate it. Thank you.
Thank you. Any other questions or comments?
No, thank you.
Hearing none. Thank you, Patrick. I'll take a motion for vote. Have a second?
Second.
Second. All in favor, please say aye.
Aye.
Aye. Anyone wish to abstain? Any opposed? Okay, project move forward. Our next project is the New York State Office of Mental Health, New York State Psychiatric Institute, Columbia Gambling Disorder Clinic. This is in New York City, a Part 824 specialized service for problem gambling. This is a program that deals with individuals who have a primary diagnosis with problem gambling. They incorporate various treatment as motivational interviewing, craft, CBT, working with both the individual and family members. Their average length of treatment is 3 months, and then they refer out to other additional needed resources. This is an entity that does not bill for services because of their status as a research institute, and require grants and OASIS funding to provide the services to their clients. We did have some discussion about, because they're part of a research entity, is their actual research done with the clients they see, where the organization said, no, it's not part of their clinical treatment services. And the other question was individuals who have more serious mental illness and or co-occurring disorder. And the organization made it clear that they only serve people who have a primary diagnosis of problem gambling and may experience some anxiety, depression, but then would refer out for more intensive services if that was the primary diagnosis. Any other, and their primary population is 18 and older for this clinic. Any other discussion, questions from the group? Okay, I'll take a motion for a vote. Can I have a second?
A second.
All in favor, please say aye.
Aye.
Anyone wish to abstain? Any opposition? Okay, project carried. We're getting close. Our next project is Rippling Waters Retreat. This is a new OASIS provider, Part 820, for residential rehab SUD services in Delaware County for a 9-bed male facility residential program, providing individual, group, peer, and family support. They have a 30-60-day track. This is a somewhat unique program, and we spent a lot of time focusing on their budget, which was a little confusing for us as we looked at it. This is basically the cost is $1,000 per day, private pay. They did allocate 1 out of the 9 beds for use of the county to utilize for individuals as well. And this is a couple that are licensed clinicians. They have property that they've paid taxes paid for, and the budget that was presented, which is a little confusing if you look at the documentation, is the revenue $2.5 million, the expenses $124,000, with a net profit of $2.3 million. Thanks to Sabina, we were able to clarify that this is their startup budget. They haven't seen people yet. But when we looked at their annual revenue and expenses, they did match up, so it did appear to be appropriate. They do have a fully staff. They do not accept commercial insurance, so they're in their startup phase at this point. Any other questions or comments from the group?
What was their response? They were there, they in attendance?
Yes.
What was their response when you brought up the issue of the financial issue?
Well, they assumed that the project review committee had the entire budget. We did not have access. We just had their startup. So we were all scratching our heads and saying, how can you operate with all the fully staffed and everything? So it was clarified. Otherwise, it seemed like a much needed program, committed staff and presenters.
Good point, Michael, about the much needed service, because one of the things, and I was saying this to Debbie Ann earlier, this is one of the projects that's located in what we call like a desert area. So that's the good thing about, this project. It's really filling a much needed space in the area, but, understanding their model financially was what we got caught up with. But we resolved it.
Thank you, Sabine. You had the right question. All right, I'll take a motion for a vote. Can I have a second?
Second.
Thank you. All in favor?
Aye.
Anyone wish to abstain? Any opposition? Okay, project moved. We're down to 2 left. Our next project is Rockland Recovery House. This is part of discussion of a new certified recovery residence. This is in Stony Point, Rockland. where they have 8 beds, 6 bedrooms for males. They do require a $700 per month fee. And they have a house manager full-time on staff. And the residents have to attend outpatient treatment and AA meetings of their choice. And over half the residents are employed as well. So this is, as we talked about, a new certified recovery home, and we're happy to see that they actually came forward and presented. I think this is the first one that we've seen at our project review committee. There were some questions about folks who are not able to pay $700 and what type of equity and scholarships and other support do we offer residents who may meet the requirement or need but don't have the ability to pay. Any other questions or discussion points? Okay, I'll make a motion for a vote. Can I have a second?
Second.
Thank you. All in favor?
Aye.
Aye. Any abstentions? Any opposition? Okay, project move. And our final project for Oasis is St. Xavier Home Care Service, Inc. This is a new Oasis provider for comprehensive outpatient program located in Forest Hills in Queens. This is a program primarily addressing opioid treatment, and there were questions about hours of operation, which the organization talked about primarily dosing in the AM, but they do provide full MAT counseling services with the primary population of 18 and older. They hope to serve at their peak 400 to 500 individuals. And again, there was confusion about the budget, but when fully operational, their expenses will be $2.7 million. So it does align with their revenue and their expenses as well. There is an ownership of 3 individuals. And again, their expenses and their revenue matched after further review. Any questions or additional comments from the committee? Okay, I'll take a vote for a full vote. Can I have a second?
Second.
Thank you. All in favor?
Aye.
Aye. Anyone wish to abstain? Any opposition? Okay, project moves. So thank you, Project Review Committee and Full Committee and Oasis and OMAID staff. We did a lot and covered a lot of ground, so thank you. Glenn, I'll turn it over to you.
Thank you so much, Michael. I really appreciate it, and thank you, Patrick, Hilda, and the staff of OMAID and Oasis. I really appreciate it. So we have the commissioners with us today. We're very excited to have them. Thank you both for being here. So I think what we did this year, and you guys generously said, please put something together for us, and we did. We have put together, first time I've been here in the 5 or 6 years I've been here, we actually put documents together with our sort of our proposals. Now, I know it was late in the game, it's still later than it should be. It'd be nice to get it to you in August. I apologize for it coming in later, but we did put our series of recommendations together. And we were hoping from your end to talk about sort of our recommendations and also what you can forecast in the budget. I know it's very difficult, obviously. We're in December and things change every minute, I get all that, but we were hoping to sort of have a conversation with you about the budget and sort of our priorities as a group as well, so you know exactly where we stand. And we're pretty consistent, you probably do know, but it's good that we documented it. So thank you both for being here and presenting. I will say this morning, I was over at the Assembly, had a hearing on workforce. So I spoke at that, and there clearly is an interest and an appetite to hopefully continue from there and continuing to fund the workforce piece around the 2.7% ask. Listen, you know, there's always an appetite, but when push comes to shove, who knows what happens. But anyway, that said, we're really pleased to have you here and just let us look at your take on our recommendations, but also where you see us going, obviously with the budget commission. So, every one of you wants to take the lead?
Flip a coin? That's an easy discussion, and where the budget's going, I mean, those are not good conversations. So, that's, yeah, I mean, I'm sure there will be a rush of activity in the next coming weeks, but I can tell you, that's not.
Yeah, there's nothing firm. I mean, I think obviously, what you have in here are issues that are buzzing around, but we really can't really say anything about where the budget is kind of at right now. I mean, we can talk to a little bit some of what you suggested in terms of, theoretical, but it can't be specific about the budget. The budget really, like, as Johnson said, really hones down in a couple of weeks before. The state, and that even continues after the state of the state in terms of what the government puts in. So, there are lots of ideas floating out there. It wouldn't be good to talk to many of them.
So I need to jump in here. Can you hear me in New York City?
Yeah.
You guys
Yes.
we cannot hear the commissioners because you're too far away from any of the polycoms.
You guys wouldn't mind moving up?
And Glenn, we can't hear you very well either. Commissioner Sullivan, are you planning to start with the presentation on the federal impact?
I don't know that you wanted the federal impact or not, or you want to just discuss this. Plan started.
Yep, sorry. I always kind of like. I try not to. So I think we probably do want to sort of get a sense what's going on from federal perspective. Absolutely. I think that's really important. So I think that's, I assume everybody wants to
So
do
would
that.
you want to do that first? Or?
Sure.
Okay, so I'm gonna, so then we flipped a coin and I lost. So I'm gonna present it, but Tanazo's gonna kind of just jump in on anything
I'm sorry,
that.
Glenn, would it be possible to sit in the other side?
Oh, sure, of course. No problem.
It's a clean polished version that lands professional. I think much of this you've heard before, so I'm gonna flip through some of it kind of quickly, but again, you can have the slides for the details. But the big thing is still the HR 1, which was all about the shutdown. Now there's supposed to be some degree of talking about this, but nobody knows really where they're at or what's going to be happening. Again, the big impacts on the HR 1 for us are Medicaid. And ultimately, it could be a $14 billion hit to the state. If everything that's in the HR 1 goes through. So that's huge. And that will definitely impact in terms of what we have to do to make up that kind of a loss. So the key areas, next slide, the key areas that it hits, the first big one is, as we've talked about, well, just to keep in mind the numbers here, that there's 7.5 million New Yorkers on Medicaid, and it's only 20 million New Yorkers. So it's a third of the population is on Medicaid. So it's a huge insurer. It's huge to the hospital system. It's huge to everything. It's huge to individuals being able to get the care they need. So, and we're expecting that if everything happened, up to a couple of million New Yorkers could lose their coverage. So it's not clear what will come. And so the things that are in there, which I think we've talked about a lot, next slide. The first one is the essential plan. If that hits in January, the essential plan was the Obamacare extensions that enabled more and more people to get insured. And New York did that, and New York ended up with only a 4% uninsured rate with all those expansions, which is incredible. It's one of the lowest uninsured rates in the country, but now it's going to go up. And basically what the state did is, it's complicated what the essential plan was, but there was a way to go back to a basic plan that would enable a certain number of New Yorkers to now get insurance at full pay from the state. So with no federal contribution. So the state is doing that to cover a good percentage of the people who would have fallen off from the essential plan. However, 450,000 will not be covered no matter what, because they are just totally ineligible for Medicaid, period, even if the state wanted to pay the full Medicaid. So those 450,000 individuals are by and large the lawful immigrants here who are working and paying taxes, who were covered before under Medicaid but now can't be covered. So that's a big hit. And how they can go to the market, you know, if you where there is still the health marketplace in the state, they're significant rates. I mean, there's no way that most people who were covered previously by Medicaid, who are eligible, because they fall out of the total eligibility. It's not just the income level, it's the total eligibility. So that's a really significant issue. And if you figure 450,000, 10, maybe 5 to 10%, maybe would be seeking mental health services and substance use services, you're probably talking about somewhere in the range of 25 to 30,000, maybe uninsured individuals hitting the system one way or the other, if this goes through. So it's a very serious hit to the system, and it's going to be, we're going to have to try to keep track of what the volume of that is. The other big issue is the recertification every 6 months. People are going to fall off because of that, because that's what happens. And then the third big thing is the work requirements. Just on the work requirements, we are talking now with the Department of Health about this. They haven't given guidance yet from the feds, and they don't have to until I think it's maybe July of next year. They don't have to give guidance, but DOH is looking at ways to be able to keep, if we get some flexibility, as wide a range of people exempted as possible. So we're in the process of working with them on various criteria using, certain ways that we look at Medicaid and individuals in Medicaid so that we can get a system where hopefully we can get as wide a berth of individuals with mental health diagnoses or substance use issues that can still be exempted from the work requirements. So we're looking at that and trying to figure out how to do it. Just to remember that the psyche system does have people's, anybody's recertification date is in there. So we're going to be working with our guys to see if we can get reports out of psyches that providers can use if they want to and say, these guys in my clinic are out, their recertification is up, because it's not one particular time in the year with Medicaid. Everybody's different. So we can pull that out of psyche, so that can be a little helpful. And we're also working with DOH if they can get us some data runs that we can get to people as well, just so people know and can kind of work with the clients about the recertifications, because that could be a big list. There's an estimate of, almost 1 million people that could at one point in time lose their Medicaid because of that. So that's serious. And then the look back period is less too. So instead of 90 days, in other words, if I get my Medicaid in 90 days, it's now 30 days. So that again hits providers in not a good way. So there's just really nothing good about this. Let me just do that. Next. So I think this has been around for a while. The only thing, the essential plan hits in January. All the other stuff, the eligibility, the work requirements, that kind of stuff, that's later next year if it goes through. The SNAP changes, I think people are aware of, even though we got through the pause. There's a tremendous number of individuals who lower their SNAP benefits. And there's this able-bodied thing embedded now in SNAP too that you can only get it for 3 months. This is going to affect our guys. It's going to affect some of our people in housing who, in a big way in terms of SNAP. So that's not good. The next one is, this is the homeless services. Now this has currently been paused temporarily because of a bunch of lawsuits that went through to the federal government, including suit by New York was part of those suits. The big problem with this is a shift from paying for HUD paying for permanent housing versus transitional housing. And the New York State, our housing that OMH pays for, we have about 51,000 units. Only 1,000 of our units of those 51,000 are connected to HUD funding. The rest is all state funding. So those are okay. But there are another 15,000 about housing units across the state for supported housing that are connected through the COC and HUD. We don't know. We're trying to find out how many of those maybe have, we figure probably a fair number, mental health issues and substance use issues, but we kind of don't know. We're trying to figure that out. At least probably 50% plus.
At least.
At least.
In our system, 100%.
Yes, so it's big time. It's big time problems. So if that goes through the way it's designed, we could have serious problems with the housing, that HUD housing. Now, we're looking at all kinds of ways, because even though this has been paused, they are saying that they will send out new guidance in January. And God knows if it'll be any better when they send it out. It could also, hopefully they give more time. But we are trying to look at ways that we can support the individuals. Like one example is, for example, we have some housing that in certain parts of the state, they've been having trouble finding apartments. So the housing is there. I'm talking about the apartment rentals, not the buildings, the apartment rentals. So they're empty because we can't, not they're empty, the money's there, but we don't have the apartment because the rents are too high, we can't find them. So what we may do is think about a way that some of that could be shifted to people who are in apartments already. And then, so there's things like that we're talking about to look at, to how we can support some of this, but it's a big number. 15,000 housing units is a big number. So everybody's working on it. OTDA is looking at it. Office of Temporary Disability is looking at it very closely to try to see what they can do, where we can find other sources of funding if this comes through. 30% can remain permanent, but then, there's the other percent can't. And then there's also the whole Housing First issue with this, and that they don't, that can make people ineligible, which makes it even more. So we're trying to figure out ways that we can be helpful with that. So this is very, very serious. So we're on a pause. Thank God there was a tremendous uproar about this, and it's one of the first things that we've gotten. In fact, they ended it before the lawsuit. They pulled it back because they realized it was so bad. So there's a lot of push. We'll see what will happen, but this is very serious. Next one. Next slide. The good things keep coming. This one, we don't know what the impact of this one will be, but this is that funny law that was passed under Clinton administration that really said that you can't give services of any sort to illegal people who are not here legally. Over the years, all the presidents kind of expanded it. May said you could do it for emergency, you could do it for this, you could do it for that. They extended the criteria so that we began to use it out of mental health block grants and other grants that came because there's now, they deliberately started to slip in things. Well, they've reversed it all back to the original. And that could be very serious if they really go forward with this and stick with it, because it can affect maybe block grant funding, maybe even some of the CCBHCs, but we don't know yet. So that one's on the radar. Next one. This is just the reorganization of SAMHSA. So far, it hasn't actually happened that they've pulled all these agencies together, but they're still talking about it. And basically, SAMHSA is at less than half staff right now. They've just decimated. The block grant program, remember they had said they were going to combine all the block grants, but they're negotiating with us as if they're separate. So I don't think that's going to happen imminently. I think we're probably somewhat safe about that for this year anyway, which is good because we've been negotiating with them about the block grant with multiple back and forths on the verbiage.
Yeah, and let me just say a word about that. We are involved in these incredibly, stupid, honestly, back and forth with the federal government about these terms. Like, it's literally just using words. And so I think the good news is nothing's changed. No activities have changed. Every single thing that we're doing, we're continuing to do, but we're changing the way that we write about it and the words that we use to describe it.
That is.
Right, and it takes a lot of time, and there's all this, it's not like, can you just tell us what word to change? But it's like, oh, this doesn't pass. And we're like, what word are you looking at for us to change in this paragraph or on this page? And it's literally, and it's all the states are saying the same thing, and
That's what I was gonna ask.
All the
it's the same.
All the states.
All of it. So
And providers who are funded too, because in our
Right.
HOHC, they're throwing everything back and we have to scrub and
Right.
it's just insane.
Right, so it's the block grant, it's the individual grant, it's across the board. So yeah, it just takes this administrative toll, right?
It's an AI search. They pull out the words, but they don't tell you which word.
Right, exactly.
They just say,
Exactly.
They just say your paragraph is not appropriate. You go, and then we finally found one. It was underserved. Can you believe it? Underserved. I mean, underserved. They wanted it out.
Yep.
So we finally changed that word to something else.
The level of minutia and stupidity is just.
My favorite one is one that actually was on the medical side, where they had the word. It was a research grant for the retina, and they had used the word. They used the word diverse because, because of the setup of the retina and the diverse cells, and they killed it because it was diverse. Really. So it's just bizarre. It's just totally, completely bizarre. It's just totally bizarre. So anyway, so when we were all going through this, it's really. And the nice thing is, I think we've had this experience. The people at SAMHSA, who understand, are really lovely. I mean, they're very helpful. They respond when we call and say, I don't understand. What's wrong with this one? So they're trying their best without kind of saying too much so that they can get in trouble. But so far it looks like, maybe the block grants this year will be okay, which is really important out there. Because what the block grant does support a lot of services. Whether or not it's going to get caught a little bit in who it can provide the services for, that's the only thing we're still worried about, but at least it's there.
And I want to say the SOAR grant as well for OSS is also same thing, looks to be like it's not going to be affected. It looks to be separate, not combined, and not really impacted by any major cuts. So that's what it looks like.
Yeah, so fingers crossed on that one. The next
So I have a question related. Can I ask it now? So for providers who are funded through either SOAR or block grant, are you advising those providers to change their language as well? What's the take? How far is it dipping for you?
Yeah. So it's interesting. So in our block grant, we don't go into this level of detail with programs we don't really provide that information. With the other discretionary grants, we do, and they are going down into that. So for example, we have another SAMHSA grant that's just focused on opioid overdose response or something like that, and there's 5 programs that are subcontract. They're going into that program information and doing the word searches, and some of it, this is the names of the organizations are triggering things, right?
I know.
Right, and so then it's the same exercise. It's the back and forth with the programs to say this is what we're planning to do to change the language, and we've had some programs respond in ways like we don't want you to change that, but it's also we're not telling you to do things differently, but we're changing the language. So there has been some back and forth with the programs, and ultimately things are moving forward, with the language change, but without changing activities for those. But the block grants doesn't name names like that. It's a much higher level.
But if they ever kind of wanted to check where the money was going, so to the extent, I wouldn't get crazy about it, but to the extent that you can modify it might not be a bad idea. Because if they ever delve down,
right, and
they're not now.
I think it's right.
But I don't know. They could at any point say, give us, something.
Because we've done our exercise because we're federally funded. But in talking to providers across the field in different associations, there's some pushback.
Yeah, but I think it's probably wise, especially if you're starting to do anything new, I would be careful what you write. And then if it's old and it's very prompt, you might just think about it. Because at some point you never know what they might ask you for.
Although, let me just say too, with that, we haven't changed. So this is the extent of the games a little bit. We haven't changed our strategic plan, and the word diversity and the word harm reduction and the word all these are in there, right? So what we've been instructed to do is remove that as an attachment, and instead have it stated like you can refer to our strategic plan, but that's not part of the attachment to the
grant.
To the document.
right. So, so that's on our website, that's our strategic plan, that's our whatever, right. So, and there's many plans like that, right? There's the prevention, framework, there's the all of these things. And it's like, we're not going in and changing any of that, but we've been instructed to not include that as an attachment.
No harm, no foul.
So, just to give you, yes, just.
The semantics of it. Maybe you could spell diversity differently. Maybe there's
A typo.
exactly, diversity or something.
Just drop a letter,
That's right.
and then AI will pick it up.
Diversity.
Right. It's a good idea. So there are various ways that it's very sad. The COVID vaccine, just so people know, this was, the governor has said that certainly in New York, we can give, the pharmacies can do the COVID vaccine by the old rules. And basically, and most of the insurers are paying for the vaccines. But if they're not, then the Department of Health does have access to vaccines, so you can get those across the state. And they've also issued a number of things, like now the hepatitis B one is in place, and New York State has clearly said that, we still recommend and want all our doctors, and we will be paying for the hepatitis B vaccine for the kids. So it's, this one is really also horrible. It's really horrible. Next slide. This is just all the diversity. We are still doing all the work. It's not like we have cut any of it, but we are playing a little bit of the game with the verbiage, with what we send in. And in terms of those executive orders on mental hygiene commitment laws and mental health AOT, we are following New York. I mean, we're not doing anything any different than we currently are. And there's a whole lot of suits about that too, because states basically have always done mental hygiene laws. These have never been tampered with by the federal government. So there's a lot of suits about that, but we are just following New York state law. We're not changing anything relative to what they were asking for. Okay, the next slide. Just two other quick up. We did most of this. The CCBHC funding for the programs still seems to be somewhat positive in Washington, and there's even a bill that's been proposed bipartisan on CCBHC, so we're hopeful that the CCBHC dollars will be there in one way or the other. And then the NIH, NIMH funding, which originally was decimated in the original HR 1 by 30 or 40%, seems to be how they're not supporting that as much. So we're hopeful. There's been some communications that they are keeping that steady, which is also really important, because once you go after that kind of funding, if you really destroy the structure of funding for research, boy, it can take years and years and years to get back again. So hopefully that there's a change in heart about that from the original HR 1, which was the president's bill, because that was a huge slashing in the funding to NIH and NIMH.
How does it work in terms of funding for NIH and NIMH for a psychiatric institute for Nathan Klein? Is that a bulk of their funding? Do they get that funding?
It's a big chunk of the funding. A big chunk of the funding is federal. The other, they also have, industry funding and foundation funding. A lot of foundation funding in both of them, but a big chunk is federal grants. So
And the same thing is true for National Institute on Drug Abuse and the National Institute on Alcohol. So no change, it really has held steady despite that initial proposal.
So hopefully that'll be okay. In fact, we've been getting some renewals on grants, slowly seeping into NISBE and Nathan Klein and the others. So I don't know if they're touching this. So hopefully they won't.
I have a quick question, if I may, on the CCBHC. On the federal side, are we seeing a sustainability and growth of CCBHC projects, or just the sustainability? And if we are seeing sustainability and growth on the federal side, and I know it's a question you probably can't answer, but I'll put it out there because it's on the minds of providers. If there is that sustainability and growth of CCBHC, would New York State have the appetite to increase the number of CCBHCs as it did in the prior funding cycles.
I think it looks like it looks like there's support. I mean, we put in, for example, the New York State SPA for the CCBHCs, and that's moving. We don't know if it's going to finally get approved, but it's there, it's moving, it's not. These feds, I don't know if they're into expanding it that much, I think it's much more maintaining it.
Yeah.
I think there's a little bit of what was proposed in that bill that the National Council just talked about were some changes that enabled, for example, like primary care to be, CCBHC. We haven't been able to do that, and a few other things, but not really an expansion. But they haven't cut the grants that were out there. So the expansion to the other states is that were previously funded is ongoing. They didn't stop that. But I haven't seen anything that says that they're going to expand yet further beyond that.
There's a lot of advocacy from the National Council, I can speak to that, for expansion to the other states and some private funding as well.
Yeah. So they're pushing, we'll see. I think, New York, I think it's hard for New York, so much has to be decided on how bad it hit to Medicaid and SNAP and education. We don't even talk about education, but education got creamed. And basically, mental. There were significant mental health services being provided through the feds, through Department of Education to New York, and those were hit. So I think that there's so many other places, so it's hard.
Medicaid is a big part of
And
the CCBHC.
There's Medicaid. So I don't know. But we are going through the SPA, which is the important thing to sustain. If we get the SPA, we'll be able to sustain what we have. And then we'd have to see what happens over the next few years.
I just also want to say, when you talk to other states, the amount of CCBHCs that we have in New York just is so surpasses. I mean, other states are like, we have 4, we have 6, and we're like, oh, we have like 39. We're totally at different levels, and so I do think the issue is really thinking about making sure that those are protected, right, moving forward, just when you look relative to what's happening across the rest of the country.
And I think also it might be a time for us as a state to, and I know this concept had been floated a couple of years back, looking at the CCBHC light and what that might really look like for agencies who, can be tiered up to be modeled in some way, like that. And then
not having to do all the tours?
Yeah. Remember, some years back, they do less of the core, and so I think those are some of the things, to your point, where we are already at 39, but given the robust system that we have and the complexities that we treat, and everybody tends to come to New York for treatment.
Do other folks have questions about CCBHC or anything else to this point? Anybody across the state?
Glenn, just a question, if I might ask, probably for you, Joe, but Commissioner Sullivan, just really appreciate all the work that I know is going into the scope and pervasiveness of all of these challenges is I'm sure daunting, and even listening to it makes me tense. So I can't imagine what you guys are going through every day. So with that in mind, given the at least pretty good potential for providers facing more clients, whether ones they're already serving or ones that are going to be knocking on their door in the near future that may not have any form of insurance. Is any discussions around increasing the capacities? And I know, even saying that, I know that's difficult to think about, but the uncompensated care pool for providers?
Yes.
Are you for CCBHCs in particular, or just in general?
No. For all licensed programs.
I mean, I can tell you what we're doing at OASAS is, well, actually what we've done is we have actually closely looked at all of our outpatient providers and our residential providers at the numbers and proportions of individuals who are underinsured or uninsured. And we have developed a formula and then given dollars according to, again, what their previous losses were and how many of their patients are uninsured or underinsured. And this is with an eye towards the future, basically saying, well, you're taking care of a lot of people and you're probably going to be taking care of even more people who are going to be uninsured and underinsured going forward. And so provided dollars that were quite flexible in what the programs could use them for, to, like, you know, continue to expand their capacity, et cetera, et cetera. So we've had meetings, with the providers and provided their funding amount that is going to happen, I think, this year and next year. So it's a way for us to be very proactive in anticipating what's likely to come in terms of the expanded number of individuals who are likely to be uninsured or underinsured. So that's what we've done at OASAS.
And those funds are greatly appreciated, by the way. Thank you.
Yeah, we have the formulas, the current formulas that we use for the uncompensated care for all of our, the clinics, and there's the uncompensated care pool for the CCBHCs as well. So we have all that we've been using over the years, and we'll probably see, by and large, we use most of them, but there is always a little bit of the uncompensated care pool that maybe doesn't, and so we're figuring out how to distribute that as it's needed. Main thing is going to be for providers to keep track of this and kind of get the bills into us. Let us know what is and isn't compensated. I think that's really critically important, so that we have a sense of the volume of what it is. But we're using the formulas, right now we're using the formulas we've kind of always used for the uncompensated care pools, and then depending upon where they go, we'll be talking with budget and others about how to help with the providers. The other thing, which I have a few slides on at the end, but you don't have to, is to really make sure that we get every penny from the commercial insurers. And I think we need your help with that. So if you've got anybody coming in your door who, in the past, we didn't pay that much attention to it. Sometimes uncompensated care was paid for the people who, couldn't get through the insurance morass of their commercial insurer. And if you said you didn't get paid, we paid. But we need to know those guys so that we can go after the commercial insurers, because at this point in time, it's really critical that everybody pays their fair share. So we need to know if you're having commercial insurers who are not reimbursing you for the care, or that or clients who are having trouble, they can call CHAMP and that kind of thing, because we've got to get every penny into the system that we can get in. And so working on the commercial insurers is important for us, as well as working on, looking at the uncompensated care pools, and because the more we can do that, we can maybe balance off some of the losses, maybe lower what in the past we used to pay for, and use those dollars then for other people who are
We've
truly
seen major
uncompensated.
improvement in our school-based satellite clinics and commercial insurance. They've really gone up this past year. So
Yeah, and that's one area. If you've got school-based satellites and you're not getting paid, then we need to know, because they shouldn't be getting away with that one at all, and they should be paying the Medicaid rate. And also late payments. If you're getting any trouble with them not, somehow they're not coming, or you begin to get a cluster of administrative denials, either from Medicaid or we need to know, because I think what's going to be important is to keep the revenue moving as closely as possible. And we do have people who can help enforce it. And while to some extent, for example, the administrative denials and things, we monitor this a lot in the clinics, and to the extent that they got better, they're also starting to slip again. So if you're in the area where they're kind of slipping, let us know, because we'll get to those insurers. Because you guys run on such a thin margin, we need to be able to get the money to you promptly too. That's part of it, and not get caught up in these administrative denials that then delay all the payments, and you have to fight to get the money back. So we need to know all that, and we can definitely pursue it. We have some money to watch out for that kind of thing. So please keep it.
Yeah, unless there's someone else online that we can't see, but thank you so much for all of your leadership. I think a couple of different points. One specifically around commercial payers is that Blue Cross Blue Shield, particularly in Michigan, has been promoting downgrading of telehealth billing. And so just being mindful of sort of statewide advocacy issues related to commercial insurance and telehealth, particularly for behavioral health billing. One other thing, going back to your earlier
You mean
point-
they've been paying less, they decided to pay less?
Yes.
For behavioral health though,
For
not
behavioral
for FQHC rates.
No, for behavioral health. So I can give you some more information
Uh,
related to that,
yeah.
but I think that that's an impact obviously for all of us. But with regards to the CCBHCs, we're always trying to promote more integrated care, so thinking about CCBHC's FQHC coordination in terms of, because they're obviously going to see shared, maybe some of the population, but on both ends of the spectrum. That's one thing. The second thing is in thinking of CCBHCs and furthering the OASAS OMH initiatives, is that an opportunity as we review some of the regs, to really bring that together in terms of really creating that model that you're both envisioning as an opportunity. And then I think the third thing is, when you're saying the DOE dropped $1 billion in school-based mental health funding, which just happened overnight. And I think that that's a great example of how we can best reinforce the school-based mental health component, because obviously the funding for mental health services comes from different buckets depending on your age. And for kids, a lot of it is DOE, so just thinking about how we can best support some of those initiatives.
Yeah, I think we're looking at, we're rethinking some of ways to get more the school-based mental health services into the schools. It's because some are very successful clinically and financially, and others seem to have more trouble. So we're in the process of figuring out ways to kind of help the ones that seem to have more trouble with that. Because I agree with you, there was a lot of money that went into the educational system to help the schools do mental health services that's now gone. So it becomes increasingly important to help them in other ways. And we are working on the connect. What?
I don't know if it's a good thing you guys are laughing or.
We're working on the. One of the things I keep telling myself, I've been promising for years. I mean, how many years can you promise, right? I've been promising for years that we would get those flexible regulations into the CC. And we're getting there, but we hit some glitches in the actual statutory thing, which we may have to fix.
And is that something that you can?
Yes, that's
share
something
with
we're
the
working on.
provider with,
Yeah.
so we can.
Yeah, well, we can when we get there. We're not there yet, but
Good.
yeah, but when we're ready, we will. But
Right.
it's an issue.
Yeah.
We were hoping we were gonna be there. We thought we were gonna be there for this meeting, but then we found this glitch and then and then it got pulled, so it was just.
But
this is
everybody's
why,
on
because
top
we all
of it.
thought we were like gonna be here with today, with the
That's what
the
I'm
whole set of
thinking,
regs.
break up the
Like,
For once,
exactly.
but we're getting there. We're getting there. It's
Yeah.
not from
We're
not
on
trying.
fence with the two of you.
Not that you can believe that anymore because
We will-
we've said it
we
so
will
many
get there.
times. But it is. So we're working, and hopefully there's going to be a
The provider
resolution.
will-
Hopefully there'll be a resolution soon.
We'll be ready and set to advocate.
And just,
Yeah.
just to put this out there, it's great and we're waiting for it. There is now a cost to this
Yes.
that providers are undertaking because the requirements to integrate, now we have to pay for needs assessments, and because we're all so busy, like typically I would do my own needs assessment. I don't have time for it, so I'm looking at an additional $15,000, so if there are ways where it can happen without the all the strings attached to it that are costly would be very helpful.
Is there a fear that there must be because of what's gone on with the federal education that the mental health school-based clinics, will there be, you've done a great job of expanding them year after year. Is there a fear that you're not going to be able to expand them because of the federal cuts or?
I don't think so. I think the governor is really committed to the school-based. I think those were grants, and that's where the federal government, the money that they were giving from the Department of Ed were grants.
Okay.
And so they were, and they just cut it. This is Medicaid reimbursable through what we do, so as long as New York is keeping it in the benefit package and stuff, I think, at the rates, and I don't think the governor will back off on that, because this has been a major issue of hers to
Right,
do it in
right.
school. So I think we're pretty safe
That's great.
in the schools, and with the enhanced rate in the schools.
Yep.
Glenn,
Yeah.
no time, but can I go back and just mention something about commercial? The other piece that I think on the commercial side that we're hearing concerns about is the insurance companies increasing the co-pays on the part for the patients, for the members. So this way to offset their costs. So that's something also if we can look out for and really kind of get our members, patients to talk about.
Yeah, if you could let us know which ones are doing it, because they may be able to do it, but it could be a parity thing if they are doing it for us, but not for something else. So if you could let us know the insurer
Yeah.
that's
we're
doing
talking-
it.
Yeah, the Legal Action Center, I've been talking to Paul.
Yeah, that's great. So if they can just they should let us know, our parity group, because we will go after them. If it looks like it's a parity violation, we will go after them. I mean, some things they can do, but that sounds suspicious. If they shouldn't, they're paying, if their copay is going up there, but if it's going up across the board, we might be stuck with it. But if it's just us, then, so please let us know when you see these things, because they keep creeping up. And then we have to get to them. If they're not legal, sometimes we can get them to back off.
Yeah, there's been these anecdotal stories, so I know Paul's group has been looking into it. And it's not only in New York, it's nationally. That's
And just on the parity, one of the things you brought up was the parity. And I think that we are continuing a very strong fight on parity. I think, we've done more in terms of some of the quality parity issues in New York than almost any other state. And we're continuing to fight those battles on parity.
Yeah.
But we need information too. So if people are, if things are happening out there, we will continue to fight. You brought up the issue of, we currently are still under, for whatever reason, my understanding is we're still under the original federal parity laws, because there's been a pause on stopping it. But if that should change, we'd look at what you were suggesting, which is to codify it in New York. But right now, it's really, we don't need to yet. We don't need to yet.
I think the issue that we have had consistently is you guys have been terrific. Both your agencies have been great. I think the issues we have are with some of the other agencies in terms of enforcement actions. We haven't really seen any really aggressive enforcement actions coming from DFS or DOH. And I think those are real issues for us. And I think even symbolically, if they went after somebody who clearly, God knows, I'm sure there are lots of, plans that are doing this, that if they could clearly, even symbolically, do something, then I think that would send messages reverberate throughout the community. So that's really what we're really trying to push them on that. But was there other things from your guys' perspective?
No, I think that just one thing to keep in mind is this. This is again the the Office of New Americans is really the source of information for any immigrant individuals or families you're working with. If they have any questions about their status, any questions about who to go to or what to do, it can be totally anonymous. This is how you contact them, and they're a good group. So it's good to get the word out there, because there's a lot of also misinformation, and there's also people who take advantage of, the immigrant population, promise things that they can't deliver, and people pay. It's really nasty. So this is the place to send people, and they can then help get them, and it's a state, and they know what they're doing. So just to keep that in mind.
The only other thing that I would bring up is the federal position around harm reduction is also similar theme. A lot of words about really going against harm reduction, but in practice, again, very little change. So not counting naloxone or fentanyl test strips or xylazine test strips as harm reduction. I don't really know what counts as harm reduction, really, frankly, with this administration, but the things that we couldn't do anyways, like using federal dollars for syringes or, crack pipe kits so none of that has really changed, but, so there's a big anti-harm reduction, like messaging, but the things that have been allowed are still allowed, and the things that weren't allowed still aren't allowed, so,
And you guys are still doing your PSAs, I see that pretty
Yes.
aggressively, so that's
Yeah.
great. I know.
Yeah.
It's just reprehensible.
And we're able to see some really solid data of the impact of some of the work over the last 2 to 3 years.
Yeah, it's
pushing harm
incredible.
reduction on reducing overdose deaths. So the data is there.
Yeah.
And the other thing you asked us for was to look over all the we are doing that. We're in
Right.
the process of looking over regulations, and one which we, apparently we had something that was confusing, well, maybe it was what we were expecting, that basically if you were doing telehealth after hours, remember this one? That we were expecting you to have somebody on site. It doesn't have to be the case. So we're changing some of that. So we're looking over all the telehealth things. We're looking over some of the other regulations, et cetera. Everybody had given us a lot of information from various groups about what we're doing that we could maybe make easier for people. So we're in the process of looking at that. But that's one that we're going to get rid of as an example. And then we're looking at all the others and we'll be looking through them. I think the other thing is we'll be talking with anybody who's having any difficulty with billing and revenue maximization, that kind of thing. We have a technical assistance group that we work with that can go out and help people if anybody's having those kinds of problems. And we'll continue to get suggestions. And we're kind of pushing a little bit to be thinking of intensive outpatient. If you're doing stuff that you're not getting paid for, and we will try to fast track an intensive outpatient opportunity where you can bill for a couple of services in one day. And sometimes some facilities have not taken advantage of that, clinics, and they say, well, I'm not getting paid for all I'm doing, but then when you look at what they're doing, they could if we just license them this way for some of those services. So again, we're there to talk about that so that we can maximize the revenue, and also trying to encourage people to look at groups, because groups can be somewhat financially more successful than a lot of individual therapy. To think about that, we'd be glad to work with people and see how to do that. What's the correct way to bill, that kind of thing if you haven't been, and also training if people need it. We can talk about that and get some of that out there. So redesigning a little bit what we do in the new world to kind of do maybe some revenue maximization might be also something to think about. Okay, so that's, I think we can stop.
Very much appreciate that. I'm sure we all appreciate. Anybody on the other parts of the state have questions?
No, you can finish. That's okay, Patty, because this is on the commercial, which I went on and on about. So the commercial insurance, we don't have to have the last few. It was just to get everybody to really help us work with the commercial insurers to make sure they pay. Yeah,
That's appreciated. Anybody around the state, questions? Well, I just want to say, of course, one.
If there's no one else on. I was just curious, I know that trying to keep track of those that are losing their insurance or uninsured is going to be really important. I'm just curious about, I know that for the Motors program, there is the capacity survey that is being rolled out, and I know that adds a certain amount of administrative burden and requirement, but I was just curious whether or not that could actually be one of those different opportunities to collect data, understanding the needs of different agencies, if you're going to do it anyways. And I hear that for OASAS programs, you already have that in place. So my question is that an opportunity to keep track of agencies that may need additional support as their population, or whether or not that's actually, because data is never fully safe anymore, and so whether or not there's a risk to actually collecting that data. And I'm just curious about how to best get a heat map on sort of agencies or regions that are disproportionately impacted.
Yeah, no, we're trying to figure, we're thinking about that and trying to figure it out, because one of the reasons that we're pushing this capacity is that we just need to know these things.
Yeah.
We need to know what's your percentage of uninsured, and is that going up? And we also need to know, do you have 1,000 people waiting? Or do you have 10 people waiting? And I think, I know it's a bit of a burden, but there's no way to do it except to get to the clinic providers and ask them to give us that kind of data. And then you can tell whether you've got, areas that are really significantly not getting the services that they need. So we're trying to figure out a way to do it. We can't use immigration status in any way.
Yeah.
So it's, but I think we can still try to collect, and I'm asking them to figure this out, to figure out how you can get a number of at least the uninsured. And so if you were seeing 10% uninsured and now you're seeing 15% uninsured, I mean, where did it all come from, obviously. So I think, that's what we're trying to be able to do, and then help percentage-wise then what people are doing. And we have not, BHSAC, but we have not traditionally gathered the kind of data that can give you that.
Yeah.
And I know it's a bit of a burden to our clinic system, but if we don't have it, I don't have the same ability to push, for example, to increase that uncompensated care pool if I have no data that can show that anything's changed.
Yeah,
So-
I think this is a really good point, and one that, I was going to jump into earlier when talking about, we only, we're relying on the data that we get from our programs, right? And if we don't get those data, we can't, we're operating in the dark. And so when I talked about in terms of giving dollars out already proactively, I mean, there are programs that haven't reported data in 2 years, so they're not getting dollars. Right? And so I think, this has always been an issue, but I think even now, it's even more pressing than ever before to get that information to us so that we can then use that in all of these ways. I think the other thing at OASAS, we were very fortunate in last year's budget to really get dollars to improve our ITS system, and that will really impact the providers so that we can provide an interface to be able to provide this information in a way easier way, where we're doing a lot of the work in the background, and here's a link where you can provide this instead of the paper forms, the scanned PDFs, the systems that are 17 years old. And so we're excited about that work, and we think that will help with some of the administrative burden that the providers also have to provide this information. So we're moving forward with this in ways to try and really make it easier for everybody, less administratively burdensome, more automated, so that we can then use these data in these ways to provide the dollars, to be able to advocate, to be able to see the differences that are happening, et cetera, et cetera. So very, very, very much on our radar. And we really need to work together, with programs.
And I think that messaging part where this could actually be helpful to you is definitely a necessary part of that dialogue, as opposed to just a one-way kind of dynamic. And then the other thing I'm just going to plug, I know that this is a continuing work in progress, and I'm totally appreciative of all of your collaborative efforts, is the other agencies, OPWDD, DOE, DOH, just creating that healthy ecosystem around the people and how to best coordinate really meaningful integrated care. And so I just, any efforts we can contribute to that process, I think is really meaningful.
Yeah. No, absolutely. And there's a lot of work going on with OPWDD. It's interesting because they're not in managed care. And that, in terms of the funding streams, has caused massive issues in some ways. So, for better, for worse. For them, I think it's wise for them to stay out, but that's up to them. But it does cause trouble in terms of some of the interagency and the kinds of stuff. But we're trying to work closely with them, and I think we're getting a little bit better at it. But yeah, there's issues of that kind of integration, and I think there's a number of programs that we put up that I think are better, especially for the high need ones. But the CCBHCs, for example, can do basic, and some of them upstate are doing basic work with the development IDD population. So we'd love to see that expanded into some of the other CCBHCs. There's a couple who are doing it upstate, and we can build for that. We can do that work in the CCPHCs. So that gives much more flexibility at that level in terms of, so I think we're getting better at being able to, but yeah, there's work that still needs.
Thanks for funding an HBCI team that is focused on that population as well.
Yeah, because if that works, and it seems like we're getting some good results from them, we'll fight real hard to expand that, because I think that it seems like it's working. And so far, we've been getting some good feedback, which really helps the intensive cross kind of kids.
So,
And I just want to say on your recommendations, you know, I mean, really, we've read them over very carefully. You know, we've distributed them to staff. So we're taking them very seriously. I think we are aligned on almost all of them, whether or not aligned in terms of hope, but and I can't say I'm aligned in terms of money, but I think, you know, this really, it was very well thought out. I want to thank you for that, really. And I think there's a number of things that are, that we all want to kind of see there. So we'll be looking at them and we'll be sharing it.
thank you.
So you know that.
I do very much appreciate that. I think we all appreciate this. This was a combined document of everybody on the council putting their knowledge together. And you'll see, as you've already seen in terms of serious recommendations, we're taking it very seriously. So thank you for looking at it, and hopefully it's going to help with your guidance in terms of moving forward as well.
Yeah, no, and I think, we will be sharing it, you know, as we go forward with, you know, budget negotiations. But really, it's very thoughtful, and I think touches on a lot of what, you know, what's very important. Just the one issue that you brought up about our mental health associate, it's moving.
Yeah.
It's a little slower than I would like, but it is moving, and we now have a vendor who is putting together some of the pieces, and we're hopeful that by sometime next year, we will be able to grandfather some people into it, and then have a training curriculum. And we're negotiating with DOH about payment for that service. So it's coming. It's coming. I kind of wish it would have. I wish I could have said we'd have it tied up by July, but we don't. I think it'll have to go across next year. But it is coming, and I think
that's wonderful. You know, that's
be
great to hear, because it really, you know, obviously I have a bias because my son's one, but BHSACs have really been life-changing for so many folks. And to have similar certification credentialing within OMH would really.
Yeah, no, we absolutely, you know, I mean, we're using much of the BHSAC, you know, the model for this.
And it's a workforce nugget that
Exactly.
is well utilized and
absolutely.
has helped the system to do the work.
Yeah.
And do the work in a different type of way that's person-centered.
Yes. No, it's really cool. So we're getting there. I just don't want you to think it was fun. And the dollars to make it happen are still there, just so you know. So I mean, in terms of setting it up and everything. So so it's coming. It's coming.
We won't talk about facility cultures.
No, we're not going to talk.
We won't talk. I talked about it this morning. Go to the legislature and talk about that. That's always a great move. Not one of my finest hours.
No, that's well.
We won't go there.
Yeah, I know. But but thank you. I mean, you know, it's a very nice document and also very even-handed, truthfully, you know, in terms of the requests. So thank you.
Thank you. Thank you for everything you both do. You know, we're lucky to have you both. I think we all feel that way. So thank you. I hope you all have a good holiday.
Yes, happy holidays, happy holidays. And also thank you for coming to the BH. Thank you for being here. Thank you everybody for being a part of this. It's so important. And I was listening to all the things that go through. I mean, really approving all those services is so important. It just is. And I know this is precious time. And I know, but really, so much thank you. Thank you for being a part of this team and for giving us your ideas and for working on the capital, all the things that have to go through programming. It's very, very important.
Yeah, it is. And for Oasis, it's great to see gambling recovery.
Yeah.
It was a different variety and shakeup that came through at today's meeting that it almost caught me like, I'm not seeing an 822, you know? Not that I was looking for it, but it was different. And I think that's great to see. And I think for the recovery housing, some sort of continued education to the field about what it is and who's required and why might be nice so that, you know, folks get a nice rounded type of education on it. But I learned a lot today, just listening to the presentation, and by the responses and the discussion we had here today, I learned a lot.
We don't
So-
want to discourage organizations from taking.
Yeah, absolutely, and Brenda was here and she was able to give some feedback. So I think, you know, it's nice to see the different types of things that we're seeing come to the council.
Yeah.
Now.
You're gonna get a letter about recovery homes and
Yes.
guidance documents.
Yes, you get those recommendations.
Yeah. I mean, I think it's still, you know, these are iterations. It's that are, well, I think will continue to improve as we get more experience in this. But I think it's important areas to be expanding.
Well, I think we've reached the
Great.
end. Thank you.
Thank you.
Thank you, guys, thanks. Yes, happy holidays. Happy holidays.
I think unless there's other business, anybody have any business? Otherwise, we can adjourn the meeting.
What is our next meeting?
When is our next meeting? Patty, when is our next meeting? Patty, when's our next meeting?
The last week of February. I'm going to send a note out and just
The last
confirm
week of
people's availability. Last week of February. You have
Thank you.
holidays off. Thanks, everyone.
Yeah, thank you. Thank you,
Thank you
everyone.
all.
Thank you, Patty. Thank you, everybody, for all you've done and continue to do.
holidays.
Yes, happy holidays. Happy holidays, everyone.
Thank you too.
Well, I'll tell you, I get all of you guys today. Like I had you in this morning. Yeah. Such a nice guy.